Lesson 1. General Principles of Pharmacology. Let us begin by quieting the mind. Breathe in deeply, filling your lungs with oxygen, that most essential of all chemicals. And breathe out, releasing carbon dioxide, the waste product of your internal combustion. This simple act, the exchange of gases, is the most basic form of chemical interaction. It is the essence of life. Pharmacology is simply the extension of this principle. It is the study of substances that interact with living systems through chemical processes. The word itself, pharmacology, holds a deep and ancient duality. It comes from the Greek word pharmakon. In ancient Greece, this word did not strictly mean medicine. It meant remedy, but it also meant poison. It could even mean magical charm. This is the first truth you must internalize. There is no fundamental difference between a drug and a poison. The difference lies only in the dose and the intent. A substance that cures a headache can, in a higher quantity, stop the heart. A compound that stops the heart can, in a microscopic quantity, restart it. Tonight, we study this balance. To understand pharmacology, we must first define what a drug actually is in the eyes of science. We are not speaking only of substances sold in pharmacies or illicit materials found on the street. In our context, a drug is defined broadly as any substance that brings about a change in biologic function through its chemical actions. This molecule might be synthesized in a high-tech laboratory, extracted from a rare plant in the rainforest, or it might be a mineral dug from the earth. Even water, if administered in specific ways or specific volumes, acts upon the body's physiology. These external substances are called exogenous agents. They come from outside of us. They enter the body to mimic or block the chemicals that are already inside of us, the endogenous agents. As we move deeper into the mechanics of this science, we find that the field is divided into two great pillars. Imagine a bridge connecting two shores. One shore is the drug itself, the other shore is your body. The traffic on this bridge flows in two directions. These two directions are named Pharmacokinetics and Pharmacodynamics. You must understand these two terms intuitively. Let them sink into your memory. First, consider pharmacokinetics. This is the study of what the body does to the drug. Visualize a small pill being swallowed. From the moment it enters the mouth, the body begins a complex defensive and logistical operation. The body must break the pill down. It must absorb the active molecules into the bloodstream. It must transport those molecules through the vast network of veins and arteries to the specific tissues that need them. Eventually, the body must dismantle these molecules chemically and expel them. This journey, absorption, distribution, metabolism, and elimination, is the domain of pharmacokinetics. It is the story of the body's power over the chemical. It determines how quickly a medicine acts and how long it stays in your system. It is why you must take some pills every 4 hours and others only once a day. Now, consider the opposing force, pharmacodynamics. This is the study of what the drug does to the body. Once the chemical has survived the journey and arrived at its destination, it must perform an action. It must change something. Pharmacodynamics describes the mechanism of this change. It explains how a tiny milligram of white powder can lower your blood pressure, or relieve pain, or induce sleep. It is the study of the molecular handshake between the foreign invader and the host cell. This brings us to the most critical concept in all of pharmacology, the receptor. If you are drifting off, hold this image in your mind. Imagine the surface of a cell. It is not smooth. It is textured, covered in millions of tiny, specific shapes and structures, like a complex landscape. These structures are proteins called receptors. They act as sensing elements. They are the communication ports of the cell. Under normal conditions, your body's own chemicals, hormones, and neurotransmitters float by and attach to these receptors to deliver messages. One message might say, beat faster. Another might say, feel pain. Another might say, produce insulin. A drug works by hijacking this system. The drug molecule is designed with a precise physical shape, a three-dimensional architecture that allows it to fit perfectly into one of these receptors. The classic analogy is a lock and a key. The receptor is the lock, guarding the function of the cell. The drug is the key. However, the drug is not always a perfect key. Sometimes it is a master key that opens the door wide, stimulating the cell to work harder. We call this type of drug an agonist. An agonist mimics nature. It tricks the cell into thinking a natural signal has arrived. Think of the drug morphine. It floats through the blood and finds the mu receptors in the brain, the receptors responsible for pain control. Morphine fits into these locks just like your body's natural endorphins, but it turns the key more powerfully, flooding the system with pain relief and sedation. But there is another way a drug can act. Sometimes the key fits into the lock, but it does not turn. It sits there, jamming the mechanism. It occupies the space so that nothing else can enter. We call this an antagonist. An antagonist produces its effect not by doing something, but by preventing something else from happening. It is a blocker. It is a shield. Consider the heart. When you are frightened, your body releases adrenaline. Adrenaline seeks out specific receptors on the heart, called beta receptors, to tell the heart to race. If we administer a drug called a beta blocker, these drug molecules rush to the heart first. They sit in the beta receptors like a piece of tape over a keyhole. When the adrenaline arrives, it has nowhere to bind. It bounces off harmlessly. The heart does not race. The heart remains calm. This is the elegance of pharmacodynamics. It is the manipulation of the body's own signaling system to restore order. This interaction is governed by the principle of selectivity. A perfect drug would be a magic bullet, a term coined by the legendary scientist Paul Ehrlich in the early 20th century. A magic bullet would hit only the specific target, causing the disease, and leave the rest of the body untouched. In reality, no drug is perfectly selective. This is why we have side effects. A drug meant to target receptors in the brain to cure depression might unfortunately also bind to similar receptors in the gut, causing nausea. The study of pharmacology is the endless pursuit of better, more specific keys for the body's many locks. Let these concepts settle: the dual nature of the pharmacon, remedy and poison; the two-way street of interaction, pharmacokinetics, the body's effect on the drug, and pharmacodynamics, the drug's effect on the body; the lock and the key, the agonist that opens the door, and the antagonist that holds it shut. You have laid the foundation. The chaos of biology is beginning to look like a machine with levers and switches. In our subsequent lessons, we will explore exactly how the body absorbs these chemicals, how it distributes them to the furthest reaches of your limbs, and how the liver acts as the great chemical factory to clear them away. Lesson 2. Pharmacokinetics, Absorption and Distribution. In our first lesson, we established the duality of the drug and the body. We spoke of the lock and the key. Now, we must tell the story of how the key finds the lock. A drug in a bottle is potential energy. It has no power until it enters the biological system. This process is the domain of pharmacokinetics. To understand this, we use the acronym ADME: Absorption, Distribution, Metabolism, and Excretion. Tonight, we focus on the first half of this life cycle, the arrival and the journey. We focus on absorption and distribution. Let us begin with absorption. Absorption is defined as the movement of a drug from its site of administration into the central compartment, which is usually the bloodstream. Imagine a castle. The bloodstream is the courtyard inside the walls. The drug is a messenger standing outside the gate. Absorption is the process of crossing the moat, scaling the wall, and entering that inner sanctuary. The speed and efficiency of this entry depend entirely on the route of administration. There are many gates into the castle. Consider the intravenous route, or IV. This is the most direct path. When a drug is injected directly into a vein, absorption is technically bypassed. The barrier is broken by the needle. The drug enters the bloodstream instantly and completely. In the language of pharmacology, we say it has 100% bioavailability. Bioavailability is a critical term. It represents the fraction of the unchanged drug that actually reaches the systemic circulation. With an IV injection, nothing is lost. The full dose arrives immediately. Contrast this with the oral route, the most common way we take medicine. Swallowing a pill is a perilous journey for a chemical. The pill must travel down the esophagus and land in the harsh, acidic environment of the stomach. There, it must disintegrate. It must dissolve. If the drug is destroyed by acid, it cannot be taken orally. If it survives the stomach, it moves into the small intestine. Here, it faces the vast surface area of the gut wall, lined with millions of microscopic fingers called villi. The drug molecules must pass through the cells of the gut wall to reach the blood. But the journey is not over. The blood from the gut does not go straight to the heart. It goes first to the liver via the portal vein. This is the body's security checkpoint. The liver is designed to filter out toxins from our food before they reach the rest of the body. Unfortunately, the liver often views drugs as toxins. It attacks them with enzymes, breaking them down before they ever reach the systemic circulation. This phenomenon is called the first pass effect. Visualize this clearly. You swallow a dose of 100 milligrams. The stomach dissolves it, the gut absorbs it, but as it passes through the liver, the enzymes destroy 40 milligrams. Only 60 milligrams enter the main bloodstream. The bioavailability is therefore 60%. This is why the oral dose of a medication is often much higher than the intravenous dose. We must account for the tax paid to the liver. Once the drug is in the bloodstream, whether by injection, by swallowing, or through the skin, absorption is complete. Now, distribution begins. Distribution is the process by which the drug reversibly leaves the bloodstream and enters the interstitial fluid and the tissues of the body. If the blood is the highway, distribution is the delivery truck exiting the off-ramp to drive through the neighborhood streets. The drug travels first to the organs with the highest blood flow. These are the well-perfused organs, the heart, the liver, the kidneys, and the brain. They receive the drug almost instantly, within minutes of absorption. This is why you feel the effects of a sedative in your brain very quickly. Later, much more slowly, the drug distributes to the tissues with lower blood flow, the muscles, the skin, and finally, the fat. Fat is a reservoir. It has very poor blood flow. Drugs that are soluble in fat can accumulate there, stored away like a savings account, and then slowly leak back into the blood over days or weeks. This is why some drugs can be detected in the body long after the person has stopped taking them. However, the drug does not always travel freely. In the bloodstream, many drug molecules attach themselves to plasma proteins, primarily a large protein called albumin. Picture albumin as a large, slow-moving bus circulating in your blood. As the drug enters the blood, some molecules hop onto the bus. This is the concept of protein binding. It is crucial because a drug molecule bound to albumin is inactive. It is trapped. It cannot leave the blood. It cannot bind to a receptor. It cannot have an effect. Only the free drug, the molecules floating unattached, can leave the bloodstream and do the work. This creates a dynamic equilibrium. As the free drug leaves the blood to enter the tissues, some of the bound drug hops off the bus to replace it. It acts as a buffer, a slow-release mechanism maintaining the level of active drug in the system. If a patient has low protein levels due to malnutrition or liver disease, there are fewer buses. More drug is free. This can lead to a sudden overdose from a normal amount of medication, simply because there was nothing to bind it. Finally, we must discuss the barriers to distribution. Not all tissues are open to the public. The most exclusive area is the brain. The capillaries feeding the brain are different from those in the rest of the body. In the arm or the leg, the cells of the blood vessel walls have small gaps between them, allowing chemicals to slip through easily. But in the brain, the cells are fused tightly together. They form a seamless wall known as the blood-brain barrier. The blood-brain barrier acts as a biological shield, protecting the delicate neural tissue from harmful substances in the blood. To cross this barrier, a drug must be very specific. It must be small, and it must be highly lipid-soluble, meaning it can dissolve through the fatty cell membranes directly, like a ghost passing through a wall. Water-soluble drugs bounce off the barrier. This has immense real-world relevance. Consider an infection. If you have an infection in your skin, we can treat it with penicillin, which is water-soluble. It distributes easily into the skin. But if you have meningitis, an infection of the brain coverings, regular penicillin cannot cross the blood-brain barrier efficiently. We must use different drugs or massive doses to force entry into the central nervous system. Let these images settle in your mind. The oral pill navigating the acid of the stomach, the liver acting as the gatekeeper, exacting its toll during the first pass effect, the bloodstream acting as the highway, the protein albumin acting as the carrier bus, and the blood-brain barrier standing as the great fortress wall. This is the logic of the body. It is a series of compartments, filters, and flows. The drug is merely a traveler, subject to the currents of your physiology. In the silence of your mind, watch the flow. See the molecule moving from the gut to the liver, to the heart, and finally out to the tissues where it will perform its task. It has arrived, but it cannot stay forever. The body is a self-cleaning engine. In our next lesson, we will learn how the system dismantles this traveler and bids it farewell. We will study metabolism and excretion. Lesson 3. Pharmacokinetics. Metabolism and elimination. In our previous sessions, we watched the drug enter the castle of the body and travel the highways of the bloodstream. We saw it distribute into the tissues. But nothing in biology is permanent. A drug that stays in the body forever would be a poison. To maintain balance, the body must eventually clear the system. It must wash the slate clean. This brings us to the final 2 chapters of the pharmacokinetics story, metabolism and excretion. Together, they form the body's elimination strategy. Let us first turn our inward eye to the great chemical factory of the human body, the liver. While the heart pumps and the brain thinks, the liver works silently to protect you. It is the primary site of metabolism, also known as biotransformation. Why is this necessary? Recall that for a drug to be absorbed from the gut and cross into the brain, it usually needs to be lipophilic or fat-loving. It needs to be able to dissolve through greasy cell membranes. But there is a problem. The body eliminates waste primarily through urine, and urine is water. If a drug is fat-soluble, the kidneys cannot hold onto it. It would simply slip back through the kidney walls and return to the blood. Therefore, the goal of metabolism is chemical alchemy. The liver must transform a fat-soluble molecule into a water-soluble molecule. It must change the drug so that the kidneys can grab it and flush it away. This process usually happens in 2 phases. Phase 1 involves modification. Imagine the drug molecule as a smooth stone. It has no handles. Phase 1 reactions, usually oxidation, reduction, or hydrolysis, chip away at the stone to create a sticky handle. The hero of this phase is a superfamily of enzymes called the cytochrome P450 system, or CYP450. Visualize these enzymes as a vast workshop of tiny machines inside the liver cells. Their job is to find foreign chemicals and disassemble them. There are many different workers in this workshop. For example, the enzymes CYP3, A4, is a workhorse that metabolizes nearly 50% of all prescribed medications. Sometimes, this process results in a strange twist. There are drugs called prodrugs. These are medications that are inactive when you swallow them. They are potential energy. When they hit the liver, the cytochrome enzymes strip away a protective layer, and only then does the drug become active. For example, the painkiller codeine is a weak drug on its own, but the liver metabolizes it into morphine, which provides the actual pain relief. In this case, metabolism is not an ending, but a beginning. After phase 1 creates the handle, phase 2 begins. This is called conjugation. The liver takes a large, water-soluble molecule, often a sugar or an amino acid, and attaches it to that sticky handle created in phase 1. It is like putting a heavy shipping label on a package. The drug is now bulky. It is highly water-soluble. It is polar. It can no longer slip through membranes. It is trapped in the water, ready for the exit. This complex machinery is why drug interactions are so common. Imagine the cytochrome P450 system as a highway with a toll booth. If you take two drugs that both need to use the same enzyme lane, CYP3 of 4, there is a traffic jam. The liver cannot process both fast enough. One drug waits in the blood, building up to toxic levels. This is inhibition. Conversely, some substances act as inducers. They tell the liver to build more toll booths. If you smoke cigarettes or drink alcohol chronically, your liver revs up its engines. It metabolizes drugs too fast, destroying them before they can help you. This is why an alcoholic might need a much higher dose of anesthesia to fall asleep. Their liver is too efficient at clearing the chemical. Once the liver has done its work, the modified, water-soluble drug enters the circulation one last time to reach the exit. We now move to excretion. While drugs can leave the body through sweat, tears, breath, and bile, the primary route is through the kidneys. Visualize the kidney not as a solid organ, but as a collection of 1 million microscopic filtering units called nephrons. The blood flows into the nephron through a tiny knot of capillaries called the glomerulus. This acts like a sieve. Small molecules, including free drugs, pass through the holes of the sieve and enter the urine tube. Large things, like blood cells and proteins, stay in the blood. This is filtration. As the urine travels down the twisting tubes of the nephron, a second process occurs called active secretion. The kidney has special pumps lining the tube. These pumps grab any remaining drug molecules from the nearby blood vessels and forcibly throw them into the urine. It is the body's final purge. However, if the liver did not do its job, if the drug is still fat-soluble, a third process occurs: passive reabsorption. The drug ignores the urine flow and diffuses right back into the blood. This is why liver failure is so dangerous. Without metabolism, the kidneys are helpless, and the drug circulates endlessly, becoming toxic. Finally, we must measure time. In pharmacology, time is measured in half-lives. The half-life $T, $1/2, is the time required for the amount of drug in the body to decrease by 50%. This is rarely a straight line, it is a curve. If you have 100 milligrams of a drug with a 4-hour half-life, after 4 hours, you do not have 0. You have 50 milligrams. After another 4 hours, you have 25. After another, 12.5. It is a gentle, exponential slope downward. This concept dictates how often you must take a pill. To keep a steady level of medicine in the blood, a state we call steady state, you generally need to take the drug for 4 to 5 half-lives. This is why antidepressants take weeks to stabilize, while shorter-acting drugs work quickly. There is one exception to this rhythmic rule, which you should know. It is called zero-order kinetics. In this rare scenario, the elimination enzymes are completely overwhelmed. The factory is full. The body cannot clear a percentage. It can only clear a fixed amount per hour. The most famous example is alcohol. No matter how much you drink, your liver can only process about 1 drink per hour. This is why alcohol accumulates so dangerously fast. The linear removal cannot keep up with the exponential intake. But for most medicines, the flow is predictable. Absorption, distribution, metabolism, excretion. The drug enters, does its work, is disassembled by the liver and flushed by the kidneys. The system is clean. The slate is blank. Let this cycle soothe you. The body is constantly renewing itself, removing the old to make way for the new. The chemistry is complex, but the purpose is simple: homeostasis, balance, peace. You now understand the journey of the drug. The pharmacokinetics are complete. In our next lesson, we will ask the question, what happens when the key turns the lock? We will explore the mechanism of action. Lesson 4. Pharmacodynamics, Mechanism of Action. We have watched the drug survive the acid of the stomach, navigate the portal vein of the liver, and ride the currents of the bloodstream. It has now arrived at the target tissue. The journey of movement pharmacokinetics is over. Now, the moment of action begins. This is the domain of pharmacodynamics. Pharmacodynamics is the study of the biochemical and physiologic effects of drugs and their mechanisms of action. If pharmacokinetics is what the body does to the drug, pharmacodynamics is what the drug does to the body. It is the explanation of the miracle. It answers the question, how does a microscopic chemical change the way you feel, the way your heart beats, or the way you think? To understand this, we must zoom in closer than we have ever been before. We must descend to the surface of the cell. Picture the cell membrane. It is not a solid wall. It is a fluid, moving sea of lipids. Floating in this sea are massive, complex islands called proteins. These proteins are receptors. They are the sensory organs of the cell. They are always listening, waiting for a signal from the body's own regulatory system. Under normal conditions, chemicals like neurotransmitters or hormones float by, bind to these receptors, and deliver a message. The drug is an imposter. It is designed to hack this communication system. The interaction between a drug and a receptor is governed by the shape of the molecules. We call this steric complementarity, but you can simply think of it as the lock and key. The receptor is the lock, a complex three-dimensional maze of crevices and charges. The drug is the key, carved to fit exactly into that maze. When the drug approaches the receptor, it is drawn in by invisible forces. These are chemical bonds. Most of the time, these are weak, reversible forces, like van der Waals forces or hydrogen bonds. It is a gentle magnetism. The drug floats in, clicks into the lock, stays for a moment, and then floats away. This reversibility is crucial. If the drug bound permanently, the effect would never stop, and the cell would eventually be destroyed. We only see permanent binding in rare, dangerous toxins, like nerve gas. Now, we must distinguish between the two main types of keys, agonists and antagonists. Imagine you are standing in a dark room with a dimmer switch on the wall. The switch controls the lights, the activity of the cell. An agonist is a drug that fits into the lock and turns it. It binds to the receptor and changes its physical shape, triggering a chain reaction inside the cell. It mimics the body's natural signal. If the natural signal says, heart beat faster, the agonist says, heart beat faster. But not all agonists are created equal. We have full agonists. These are keys that turn the dimmer switch all the way up to 100%. They produce the maximum possible response the cell is capable of. Then, we have partial agonists. These are fascinating and complex. A partial agonist fits into the lock. It occupies the space, but it is an imperfect key. It can only turn the switch halfway. No matter how much of the drug you give, you will never get the lights to full brightness. They will stay at 50%. Interestingly, if you give a partial agonist to someone who already has a full agonist in their system, the partial agonist will compete for the spot and actually lower the total effect. It acts as a stabilizer, keeping the activity neither too high nor too low. Now, consider the antagonist. The antagonist is a key that fits into the lock but does not turn. It has affinity, meaning it likes to bind to the receptor, but it has zero intrinsic activity. It does nothing to the cell directly. Its only power is the power of denial. By sitting in the lock, it prevents the body's natural keys from entering. Return to the dimmer switch. An antagonist is like putting a piece of strong tape over the switch. It doesn't turn the lights off, it just stops you from turning them on. If your heart is racing because adrenaline is trying to turn the switch up, a beta blocker, which is an antagonist, sits on the receptor and blocks the adrenaline. The heart slows down, not because the drug slowed it, but because the drug stopped the signal that was speeding it up. This battle for the receptor is often a game of numbers. We call this competitive antagonism. Imagine a game of musical chairs. If there are more agonist molecules than antagonist molecules, the agonist wins the seat and the effect happens. If there are more antagonist molecules, they block the seat. This means we can overcome a competitive antagonist simply by adding more agonist flooding the system to drown out the blocker. However, once the key turns, what actually happens? The drug stays on the surface, but the effect happens deep inside the cell. This is the miracle of signal transduction. When the receptor is activated, it changes shape. This change is felt on the inside of the cell. It acts like a doorbell. You press the button outside, but the chime rings inside. This usually triggers a cascade of events. One common mechanism involves G proteins and second messengers. Visualize the receptor passing the baton to a G protein, which runs to an enzyme, which releases thousands of tiny molecules called second messengers. This is a system of amplification. A single drug molecule binding to a single receptor on the surface can trigger the release of thousands of internal signals, causing a massive change in the cell's behavior. It is how a microscopic dose of medicine can alter the function of an entire organ. Finally, we must respect the intelligence of the living system. The body does not like to be controlled. It seeks homeostasis. If you constantly bombard a cell with an agonist, if you keep the dimmer switch taped at 100%, the cell will adapt. It will realize it is being shouted at. To protect itself, the cell will remove some of the receptors from the surface. It pulls them inside. This is called down-regulation. Because there are fewer receptors, the same dose of the drug now produces a smaller effect. You need more drug to find the few remaining locks. This is the molecular basis of tolerance. It is why a long-term coffee drinker needs 3 cups to feel awake, while a novice only needs 1. The brain has down-regulated its receptors to ignore the caffeine. Conversely, if you constantly block a receptor with an antagonist, the cell panics. It thinks the line is dead. It craves the signal. So, it builds more receptors and pushes them to the surface, trying to catch any whisper of a signal. This is upregulation. If you suddenly stop taking the antagonist, the cell is now hypersensitive. The natural signal floods in and hits all these new receptors at once, causing a dangerous surge. This is why certain medications must be tapered off slowly, never stopped abruptly. Let this complex dance settle in your mind. The lock and the key, the turning of the switch versus the blocking of the hole, the cascade of signals echoing into the cell, the body adapting, adding, and removing locks to maintain its balance. You are witnessing a conversation between chemistry and biology. The drug speaks, and the body listens, responds, and sometimes argues back. You now understand the mechanism. You know how the machine works. In our next lesson, we will quantify this relationship. We will ask, how much drug is enough? We will explore the dose-response relationship. Lesson 5. Dose-response relationships. In our last session, we spoke of the qualitative side of pharmacology, the lock and the key, the nature of the interaction. Tonight, we move to the quantitative side. We must measure the miracle. We must answer the most practical question in medicine: how much? This is Lesson 5, Dose-Response Relationships. There is an ancient maxim in medicine, attributed to the alchemist Paracelsus in the 16th century. He said, "All things are poison, and nothing is without poison. The dosage alone makes it so a thing is not a poison. Water, in sufficient volume, will kill you." Arsenic, in microscopic traces, has been used as medicine. The difference is never the substance itself, the difference is the dose. To visualize this, I want you to picture a graph in the darkness of your mind. On the horizontal axis, the line across the bottom, we measure the dose. As we move to the right, the dose gets higher. On the vertical axis, the line going up, we measure the response. How strong is the effect? Now, imagine a line tracing the relationship between them. It rarely starts immediately. At very low doses, nothing happens. The drug enters the body, but there are not enough molecules to occupy enough receptors to trigger a noticeable change. This is the subtherapeutic range. As we increase the dose, moving to the right, the line begins to rise. It curves upward. This is the threshold. We have occupied enough receptors to see a spark. From here, the line shoots up steeply. In this middle section, small increases in the dose create large increases in the effect. This is the linear phase of the reaction. But as we continue to add more drug, the line begins to flatten out. It curves over and becomes horizontal. It hits a ceiling. This is the plateau. Why does this happen? It happens because of the receptors we studied in the last lesson. You have a finite number of receptors. Once every single lock has a key in it, the system is saturated. You cannot turn the lights up any brighter. Adding more drug at this point does not increase the therapeutic effect. It only adds chemical burden to the system, increasing the risk of toxicity. This shape, flat, then steep, then flat again, is called the sigmoid curve or the S-curve. In analyzing this curve, we must distinguish between two concepts that are often confused: potency and efficacy. Let us define potency first. Potency refers to the amount of drug needed to produce an effect. It is a measure of affinity, how much the drug loves the receptor. Look at your mental graph. Potency is measured along the bottom axis, from left to right. If a drug is potent, its curve sits far to the left. It means you only need a tiny pinch, a milligram or a microgram, to get a big response. Fentanyl is highly potent. A grain of salt's worth can stop pain. Morphine is less potent. You need a larger amount to achieve the same effect. But potency is, surprisingly, not the most important feature. Whether you take 1 milligram or 100 milligrams matters less than what the drug can actually do. That brings us to efficacy. Efficacy is the ability of the drug to produce a maximum response. Look at your graph again. Efficacy is measured by the height of the curve. How high does the ceiling go? Consider pain relief. Ibuprofen has a low ceiling. It has low efficacy. No matter how much ibuprofen you take, it will never cure the pain of a broken femur or major surgery. It simply cannot reach that height. Morphine, however, has a high ceiling. It has high efficacy. It can eliminate severe pain. In the clinical world, efficacy is almost always more important than potency. We care about how well the drug works, not how small the pill is. Now, we must overlay a second curve onto our graph. This is the shadow side of pharmacology. Every drug has two curves. The first is the therapeutic curve, the curve of healing. The second, which sits further to the right, is the toxic curve, the curve of harm. To understand the relationship between these two curves, we use statistics. We look at a population of people. We define a number called the ED50. This stands for the median effective dose. It is the dose required to produce a therapeutic effect in 50% of the population. If we give this dose to 100 people, 50 of them will feel better. Then, we look at the second curve. We define the TD50, the median toxic dose. This is the dose that produces a toxic effect in 50% of the population. In animal studies, this is often called the LD50, or lethal dose, where 50% of the subjects die. The space between these two numbers, the ED50 and the TD50, is the most critical territory in medicine. It is the therapeutic window. We quantify this space using a ratio called the therapeutic index. You calculate it by dividing the toxic dose by the effective dose. Imagine a drug where the effective dose is very small, but the toxic dose is massive. The curves are far apart on the graph. There is a wide valley between them. This drug has a large therapeutic index. Penicillin is a classic example. You can take a dose of penicillin that is 10 times higher than necessary, and while you might get a stomachache, you will likely not die. It is a forgiving drug. It is like walking on a wide paved sidewalk. You do not need to be perfectly precise to stay safe. Now, imagine a drug where the curves are dangerously close together. The dose that heals you is almost the same as the dose that hurts you. This drug has a narrow therapeutic index. It is a small number. Warfarin, a blood thinner, is like this. If the dose is slightly too low, the patient gets a blood clot. If the dose is slightly too high, the patient bleeds internally. Using this drug is not like walking on a sidewalk. It is like walking on a tightrope. For these narrow index drugs, we must perform therapeutic drug monitoring. We cannot just prescribe them and walk away. We must constantly draw the patient's blood to measure the concentration, ensuring they are staying in that thin sliver of safety between the two curves. We are navigating the margin of safety. There is also the factor of individual variability. No two humans are identical. Your ED50 might be different from mine. This is due to the pharmacokinetics we studied earlier. Perhaps your liver metabolizes the drug faster, cytochrome induction. Perhaps your receptors are downregulated, pharmacodynamic tolerance. This is why dosing is an art as well as a science. We start low and slow, finding the specific point on the curve for the individual patient. Let this logic settle into your understanding. The dose makes the poison, the S-curve showing the rise and the plateau, potency as the affinity left to right, efficacy as the power up and down, and the therapeutic index as the safety buffer between healing and harm. You now possess the tools to measure the interaction. You understand the risks. The general principles of pharmacology are now complete. You have built the foundation. From this point forward, we will leave the abstract world of graphs and principles. We will descend into the specific systems of the body. We will explore the nerves, the heart, and the mind. Our next lesson will take us to the automatic controller of your life functions. Lesson 6. The Autonomic Nervous System. Welcome back. You have mastered the general principles. You understand the language of receptors, the mathematics of the dose, and the journey of the molecule. Now, we leave the abstract and enter the anatomical. We begin our tour of the specific systems of the body. We start with the master controller of your unconscious life, the autonomic nervous system. Relax your shoulders, unclench your jaw. Notice that as you do this, your heart continues to beat, your lungs continue to inflate, your stomach continues to digest. You do not need to command these things. They happen automatically. They are governed by the autonomic nervous system, or the ANS. In pharmacology, the ANS is the most critical system to understand because it is the target of more drugs than any other system. To understand how to manipulate the body, you must understand how the body drives itself. The autonomic nervous system is a duality. It is a system of checks and balances, composed of two opposing branches that are constantly pushing and pulling against each other to maintain stability. These two branches are the sympathetic nervous system and the parasympathetic nervous system. Let us first visualize the sympathetic nervous system. This is often called the fight or flight system. It is your ancient survival mechanism. Imagine you are a prehistoric human walking through a dense forest. Suddenly, a tiger jumps onto the path. In that split second, Your conscious mind does not need to act. Your sympathetic system takes over. Visualize what happens to your body in that moment of terror. First, your eyes. The pupils dilate wide to let in as much light as possible so you can see the threat in the darkness. Next, your mouth. It goes dry. The production of saliva is shut down. There is no time to eat. Then, your lungs. The airways, the bronchioles dilate. They open wide to allow massive amounts of oxygen to enter the blood. You need this oxygen to run or to fight. Your heart reacts violently. The heart rate accelerates. The force of the contraction increases. The pump works harder to drive blood to your muscles. Simultaneously, the blood vessels in your skin and your gut constrict. You might turn pale. This is because the body is shunting blood away from non-essential organs. Digestion stops. Kidney filtration slows down. All resources are redirected to the skeletal muscles and the brain. You are primed for action. The chemical messenger, the neurotransmitter responsible for this surge, is norepinephrine, also known as noradrenaline. The nerves that release this chemical are called adrenergic nerves. At the same time, the adrenal medulla, sitting atop your kidneys, releases epinephrine, adrenaline, directly into the bloodstream, reinforcing this global alarm signal. Now, let the image of the tiger fade. The danger has passed. You have escaped. You return to your cave, eat a large meal, and lie down by the fire. This is the domain of the parasympathetic nervous system. This is the rest and digest system. It is the housekeeper. It is responsible for conserving energy and maintaining the body's long-term health. Visualize the changes as you lie by the fire. Your pupils constrict. They become small, protecting the eye and focusing on near objects. Your mouth waters. Salivation increases to begin the process of digestion. Your heart rate slows down. The pounding in your chest fades into a slow, steady, rhythmic beat. The pressure in your arteries drops. Your lungs relax. The airways constrict slightly as you no longer need massive volumes of air. Your digestive tract comes alive. The stomach churns, producing acid. The intestines move, pushing food along. This is peristalsis. Blood flow returns to the gut and the kidneys, allowing them to filter and clean your system. The chemical messenger for this system is acetylcholine. The nerves that release it are called cholinergic nerves. The primary highway for this system is the vagus nerve, which wanders from the brainstem down to the heart and the gut, delivering the command to slow down. This concept of duality is known as dual innervation. Most organs in your body are wired to both systems. The heart has a brake pedal, parasympathetic, and a gas pedal, sympathetic. The actual heart rate at any given moment is the result of the balance between these two signals. This balance is called autonomic tone. Usually, one system dominates depending on the situation. When you are asleep right now, your parasympathetic system is in control. It is repairing your tissues, digesting your nutrients, and slowing your heart. However, in pharmacology, we do not just observe this balance, we manipulate it. This is the core of the next few lessons. We can design drugs that mimic the sympathetic system. These are called sympathomimetics or adrenergic agonists. If a patient's heart has stopped, we give epinephrine to kickstart it, mimicking the tiger. If a patient cannot breathe because of asthma, we give a drug that mimics the sympathetic command to open the lungs. Conversely, we can design drugs that block the sympathetic system. These are sympatholytics or adrenergic antagonists. If a patient has high blood pressure because their vessels are too tight, we block the sympathetic signal, allowing the vessels to relax. We can do the same for the parasympathetic side. We can give drugs that mimic acetylcholine to help a patient urinate or digest. Or we can give drugs that block acetylcholine anticholinergics to dry up secretions during surgery or to stop the gut from cramping. You must understand that these drugs are not creating new functions. They are simply turning up the volume on the fight or flight, or turning down the volume on the rest and digest. We are hacking the body's own wiring. There is one final structural detail you should visualize. The wiring of the ANS is a 2-neuron relay. The signal starts in the brain, travels down the spinal cord, and exits via a preganglionic neuron. This neuron does not touch the organ. It connects to a second neuron, the postganglionic neuron, at a junction called a ganglion. This is important because the chemical used at the first junction, the ganglion, is always acetylcholine for both systems. It is the universal handshake of the nervous system. The difference lies at the second junction, where the nerve touches the organ. In the parasympathetic system, the second nerve also releases acetylcholine. It is acetylcholine all the way down. In the sympathetic system, the second nerve switches languages. It releases norepinephrine. This switch is what allows us to target specific organs without shutting down the entire body. It is the key to specificity in drug design. Let this duality settle in your mind. The red wire and the blue wire, the accelerator and the brake, the tiger and the fire, norepinephrine and acetylcholine. You are now standing at the control panel of the human body. You know the buttons. In the next lesson, we will press the blue button. We will explore the drugs that stimulate the rest and digest system. Lesson 7. Cholinergic Agonists and Antagonists. In our last lesson, we stood at the crossroads of the autonomic nervous system. We saw the two paths, the fiery path of the sympathetic system and the cool, restorative path of the parasympathetic system. Tonight, we choose the cool path. We are going to explore the chemistry of rest and digest. We are going to study the cholinergic drugs. Relax your body. Let your limbs feel heavy. Let your breathing slow down. You are entering a parasympathetic state right now. The drugs we discussed tonight are the chemical architects of this very feeling. The primary character in this story is a neurotransmitter called acetylcholine. It is the most abundant neurotransmitter in the body, found in the brain, in the gaps between nerves and muscles, and throughout the internal organs. When we speak of cholinergic drugs, we are speaking of drugs that interact with acetylcholine. To understand how they work, we must first look at the receptors, the locks that acetylcholine opens. There are two distinct families of these receptors, named after the natural substances that helped scientists discover them. The first family is the nicotinic receptors. As the name suggests, these can be activated by nicotine. They are found primarily where nerves talk to muscles, the neuromuscular junction, and in the ganglia we discussed earlier. The second family, and the one we focus on for the rest and digest system, is the muscarinic receptors. These are named after muscarine, a compound found in poisonous mushrooms. These receptors are located on the smooth muscles of the heart, the lungs, the stomach, and the glands. When acetylcholine binds to a muscarinic receptor, the body shifts into maintenance mode. The heart slows, the pupils constrict, the glands secrete fluids, the gut moves. We classify drugs that affect this system into two categories: the agonists, which mimic the signal, and the antagonists, which block it. Let us begin with the cholinergic agonists. These are also called parasympathomimetics, because they mimic the parasympathetic state. There are two ways to turn this system on. The first is direct acting. These drugs look just like acetylcholine. They float into the synapse, bind directly to the muscarinic receptor, and activate it. An example is pilocarpine, often used in eye drops to constrict the pupil and drain fluid from the eye in glaucoma. The second way is more subtle and fascinating. It is indirect acting. To understand this, you must visualize the cleanup crew. In the gap between nerves, the synapse there, is an enzyme called acetylcholinesterase. Think of this enzyme as a biological vacuum cleaner. Its only job is to find acetylcholine molecules, chop them up, and recycle them. It stops the signal. It ensures that when your brain says twitch, your muscle doesn't stay contracted forever. Indirect cholinergic agonists work by handcuffing this vacuum cleaner. They inhibit the enzyme. Because the enzyme is blocked, acetylcholine is not broken down. It builds up in the synapse. It lingers. It binds to the receptors again and again. The volume of the natural signal is turned up. We use these drugs, like donepezil, to treat Alzheimer's disease. In Alzheimer's, the brain is losing the neurons that make acetylcholine, leading to memory loss. By inhibiting the cleanup enzyme, we help the brain hold on to whatever acetylcholine it has left, momentarily brightening the lights in the house of memory. Now, imagine the physical sensation of a cholinergic agonist. It is a sensation of wetness. The eyes water, the mouth salivates, the sweat glands activate, the bladder contracts. The gut becomes active. In high doses, this can be dangerous. It leads to a crisis of fluids, drooling, weeping, and respiratory distress. This is actually how nerve gases and organophosphate pesticides work. They permanently destroy the cleanup enzyme, drowning the body in its own acetylcholine. But let us move away from toxicity and toward the other side of the coin. Let us look at the cholinergic antagonists, often called anticholinergics. These are drugs that block the muscarinic receptors. They sit in the lock and prevent acetylcholine from binding. If the agonist creates a state of rest and digest, the antagonist shuts that system down. It allows the opposing force, the sympathetic system, to take over by default. The prototype for this class of drugs is atropine. Atropine is derived from the plant Atropa belladonna, known as deadly nightshade. The history here is rich. Belladonna is Italian for beautiful lady. Centuries ago, women would put drops of this plant extract into their eyes. It blocked the muscarinic receptors in the iris, preventing constriction. The result was massive, dilated pupils, which was considered a sign of beauty and arousal. Of course, it also blurred their vision, but that was the price of vanity. When we administer an anticholinergic drug today, we see a specific set of symptoms. Medical students learn a classic mnemonic to remember them. Visualize this strange character as I speak. Red as a beet. Because the drug blocks the sweat glands, the body cannot cool itself. The skin becomes flushed and hot. Dry as a bone. All secretions stop. The mouth becomes like sandpaper. The eyes are dry. There is no sweat. Blind as a bat. The pupils are blown wide open, paralyzed. They cannot focus on near objects. The vision blurs. Hot as a hair. Without sweat, the body temperature rises, leading to hypothermia. Mad as a hatter. Acetylcholine is crucial for memory and focus in the brain. Blocking it crosses the blood-brain barrier and causes confusion, delirium, and hallucinations. While this sounds frightening, in controlled doses, these effects are incredibly useful. If a patient's heart is beating dangerously slowly, a condition called bradycardia, we give atropine. It blocks the vagus nerve's slow-down signal, releasing the brake on the heart, allowing the rate to rise and save the patient's life. If a patient is having surgery, we might give a gentle anticholinergic to dry up the saliva and mucus in their airway, keeping the lungs clear for anesthesia. If a person suffers from motion sickness, we use a patch containing scopolamine. This is an anticholinergic that dampens the nausea signals sent from the inner ear to the brain. You likely encounter mild anticholinergics in your daily life without knowing it. Many over-the-counter allergy medications, like diphenhydramine, Benadryl, have anticholinergic properties. This is why they make your mouth dry and your eyelids heavy. They are quieting the system. Let the balance settle in your mind. On one side, the agonist, the flow of water, the tear, the saliva, the slow heartbeat, the active gut, the preservation of memory, the enzyme inhibitor holding back the vacuum cleaner. On the other side, the antagonist, the drying of the well, the dilated pupil, the racing heart, the quiet gut, the red, the dry, the blind, and the mad. Both are necessary, both are tools in the physician's bag. By turning this single dial, the volume of acetylcholine, we can restart a stopped heart or calm a spasming intestine. You are now in control of the rest and digest concepts. The fluid nature of the parasympathetic system is washing over you, carrying you deeper into relaxation. In our next lesson, we will leave the calm waters and step into the fire. We will explore the drugs of adrenaline. We will study the sympathetic nervous system and the adrenergic drugs. Lesson 8. Adrenergic Agonists and Antagonists. In our last session, we floated in the cool waters of the parasympathetic system. We spoke of rest, digestion, and the quiet maintenance of the body. Now, we must leave the water and turn toward the fire. We are entering the domain of the sympathetic nervous system. This is the chemistry of survival. This is the study of adrenergic agonists and antagonists. Although the subject matter is intense, the racing heart, the dilated pupil, the surge of energy, you are safe here. You are merely an observer, studying the storm from the comfort of a shelter. Let your body remain heavy and relaxed, even as we discuss the mechanisms of stimulation. The word adrenergic comes from the word adrenaline. In the United States, we use the term epinephrine, but the root is the same. Adrenal means near the kidney. Epinephrine means above the kidney. They both refer to the gland that sits atop the kidneys, waiting to release its chemical alarm signal into the blood. The primary neurotransmitter released by the sympathetic nerves is norepinephrine. The hormone released by the adrenal gland is epinephrine. Together, these two molecules orchestrate the fight-or-flight response. They are the keys that unlock the body's full physical potential. To understand how we manipulate this system with drugs, we must map the territory of the receptors. Unlike the simple muscarinic receptors of the last lesson, adrenergic receptors are divided into distinct families, located in very specific places. We call them alpha and beta receptors. Let us visualize them one by one. First, the alpha-1 receptor. Imagine the vast network of blood vessels in your body, the miles of arteries and veins. Wrapped around these vessels are tiny bands of smooth muscle. The alpha-1 receptors sit on these muscles. When norepinephrine binds to an alpha-1 receptor, the muscle contracts. It squeezes. This causes vasoconstriction. Why does the body do this? In a moment of danger, you do not need blood pooling in your skin or your gut. You need pressure. By squeezing the pipes, the pressure rises, driving blood forcefully to the vital organs, the brain and the heart. This is why, when you are terrified, you go pale. The alpha-1 receptors have clamped down the vessels in your skin. Next, we move to the beta receptors. There is a simple mnemonic used by every medical student to remember where they are. You have one heart and two lungs. Therefore, beta-1 receptors are found primarily in the heart. When the drug binds to a beta-1 receptor, it acts like a turbocharger. It increases the heart rate. It increases the force of the contraction. It increases the speed of the electrical conduction. The heart becomes a high-performance pump, moving massive amounts of oxygenated blood to the muscles. Beta-2 receptors are found primarily in the lungs. Specifically, they are on the smooth muscle of the bronchioles, the airways. When the drug binds here, the effect is relaxation. The muscle releases its grip, and the airway opens wide. This is bronchodilation. It allows you to take deep, gasping breaths, pulling in the oxygen needed for the fight. Now that we have the map, let us look at the drugs, the adrenergic agonists. These drugs mimic the effects of adrenaline. The most famous example is the drug epinephrine itself, often carried in an auto-injector known as an EpiPen. Consider the condition of anaphylaxis, a severe allergic reaction. The throat swells shut and blood pressure drops to zero. It is a collapse of the system. We administer epinephrine because it is a non-selective agonist. It hits everything. It hits the alpha-1 receptors to clamp the blood vessels and raise the pressure back up. It hits the beta-1 receptors to kickstart the heart. It hits the beta-2 receptors to blast open the lungs so the patient can breathe. It is a chemical resurrection. But we can also be more precise. We can design drugs that only hit one receptor. Consider a patient with asthma. We want to open their lungs, but we do not want to race their heart. So, we use a drug like albuterol. Albuterol is a selective beta-2 agonist. It ignores the heart and goes straight to the lungs, relaxing the airways. It is a sniper, not a shotgun. Now, let us turn to the other side of the equation, the adrenergic antagonists. These are the blockers. They sit in the receptors and prevent the body's natural adrenaline from binding. They are the calmers. The most important class of drugs here, perhaps one of the most important in all of medicine, is the beta blocker. You can recognize these drugs because their generic names end in lol, like propranolol, metoprolol, or atenolol. A beta blocker works primarily on the beta-1 receptor in the heart. Imagine the adrenaline trying to dock onto the heart to speed it up. The beta blocker is already there, shielding the receptor. The adrenaline bounces off. As a result, the heart rate stays low, the force of contraction stays mild, the heart's demand for oxygen decreases. This is revolutionary for patients with heart disease. If a person has a weak heart or angina chest pain, the worst thing for them is stress. Stress makes the heart work too hard, leading to a heart attack. By giving a beta blocker, we put a governor on the engine. We ensure that no matter how stressed the patient feels emotionally, their heart physically remains in a state of rest. We separate the emotion from the organ. This brings us to a fascinating real-world application: stage fright. Musicians, public speakers, and surgeons often suffer from performance anxiety. The hands shake, the voice trembles, the heart pounds. These are not mental failures. They are physical symptoms of an adrenaline surge. Many performers take a low dose of a beta blocker before going on stage. The drug does not sedate the mind. They remain sharp and clear, but it blocks the physical manifestation of fear. The hands are steady. The voice is firm. It breaks the feedback loop of panic. We also have alpha blockers. Recall that alpha-1 receptors squeeze blood vessels. Therefore, if we block them, the vessels relax and open up. This is useful for treating high blood pressure. It is also used for older men with prostate issues. By relaxing the smooth muscle around the bladder neck, it makes it easier to pass urine. The brand name Flomax describes exactly what the physiology is doing, maximizing flow by blocking the squeeze. However, playing with this system carries risks. If you give too much agonist, you can cause a hypertensive crisis pressure so high it causes a stroke. If you give too much antagonist, you can stop the heart or drop the blood pressure so low the patient faints. This is why the body has its own safety valve, the alpha-2 receptor. This is a special receptor found in the brain itself. When it is stimulated, it tells the brain, "We have enough adrenaline now, turn it off." It is a negative feedback loop. We use drugs like clonidine to hit this specific receptor, tricking the brain into turning off the entire sympathetic outflow. It is like pulling the master switch in the fuse box. Let this complex machinery settle into a simple picture. The agonist is the spark. It is the EpiPen saving a life. It is the albuterol opening the airway. It is the constriction of vessels to raise pressure. It is the survival instinct bottled in glass. The antagonist is the shield. It is the beta blocker protecting the fragile heart. It is the alpha blocker relaxing the tight vessels. It is the steady hand of the surgeon. The autonomic nervous system is a seesaw. Balance is health. Disease happens when the seesaw is stuck, and pharmacology is the weight we add to one side to level it out again. You have now explored the nervous system in its entirety, from the voluntary to the involuntary, from the calm of acetylcholine to the fire of epinephrine. You understand the wiring. Now, we must follow the blood itself. We must look at the pipes and the pump that sustain us. In our next lesson, we will focus specifically on the pressure within the system. Lesson 9. Antihypertensive Agents. You have traveled through the nervous system, understanding the electrical signals that drive us. Now, we turn our attention to the plumbing. We focus on the pipes and the pump. We are going to study the management of pressure. This is Lesson 9. Antihypertensive Agents. Hypertension, or high blood pressure, is known in medicine as the silent killer. It has no symptoms. A person can walk around for decades with dangerously high pressure, feeling perfectly fine, while inside, the delicate lining of their arteries is being scoured and damaged day after day. It is the leading cause of stroke and heart failure. Therefore, the drugs we discuss tonight are among the most commonly prescribed substances in human history. They are the guardians of the vasculature. To understand how we lower blood pressure, we must first understand what creates it. Visualize the circulatory system as a closed loop of garden hoses. The pressure inside that hose is determined by two simple physical factors. First, there is cardiac output. This is the amount of fluid the pump is pushing into the hose. If you turn the faucet up, the pressure rises. Second, there is peripheral resistance. This is the tightness of the hose itself. If you squeeze the hose or put your thumb over the end, the pressure rises. Therefore, the equation of blood pressure is cardiac output multiplied by peripheral resistance. To lower blood pressure, we simply have to lower one or both of these numbers. We either turn down the faucet or we unkink the hose. We have four main families of drugs to accomplish this. The first family addresses the volume, the faucet. These are the diuretics. We will explore them deeply in the next lesson, but for now, understand the concept. If you have too much pressure in a water balloon, the easiest way to fix it is to let some water out. Diuretics tell the kidneys to release sodium and water into the urine. Less fluid in the blood means less volume for the heart to pump, and the pressure drops. It is a mechanical solution to a hydraulic problem. The second family addresses the pump. These are the beta blockers we discussed previously. By blocking the beta-1 receptors on the heart, we tell the heart to beat slower and with less force. We are turning down the engine. If the pump is not working as hard, the pressure in the pipes naturally decreases. This is particularly useful for patients whose high pressure is driven by stress or anxiety. But the most sophisticated drugs are those that address the third factor, the tightness of the pipes. We call these vasodilators. They relax the arteries. To understand them, we must look at the hormonal system that controls constriction. This is the renin-angiotensin-aldosterone system, or RAAS. This is a story of the kidneys. When the kidneys sense that blood pressure is too low, they panic. They release an enzyme called renin. Renin floats through the blood and finds a protein called angiotensinogen. It chops it, creating angiotensin I. Angiotensin I is harmless. It is inactive. But, as it travels through the lungs, it meets an enzyme called ACE, the angiotensin-converting enzyme. ACE acts like a pair of scissors. It clips angiotensin I and turns it into the monster of this story, angiotensin II. Angiotensin II is one of the most potent vasoconstrictors known to man. It grabs the smooth muscles of your arteries and squeezes them tight. The hose is kinked. Pressure skyrockets. Simultaneously, it tells the body to hold on to salt and water. This is a survival mechanism for a caveman bleeding from a wound. It saves his life by keeping pressure up. But for a modern human sitting on a couch, it is destructive. Enter the ACE inhibitors. These are the drugs that end in pril, like lisinopril or enalapril. They work by handcuffing the ACE enzyme in the lungs. They take away the scissors. Without the enzyme, angiotensin I cannot become angiotensin II. The monster is never born. The arteries remain relaxed. The pressure falls. These drugs are unique because they protect the kidneys as much as they lower pressure. They are the gold standard for diabetics. However, they have a peculiar quirk. The ACE enzyme also breaks down a substance called bradykinin in the lungs. When we block the enzyme, bradykinin builds up, irritating the lung tissue. This causes a dry, hacking cough in about 10% of patients. If a patient cannot tolerate the cough, we switch to a cousin class, the ARBs, or angiotensin receptor blockers. These drugs, like losartan, do not stop the production of angiotensin II. Instead, they stand guard at the receptor on the blood vessel. Even if the monster is created, it has nowhere to bind. The effect is the same relaxation but without the cough. Finally, we have the fourth family, the calcium channel blockers. These drugs, like amlodipine, work directly on the physics of the muscle cell. For any muscle to contract, whether it is your bicep or the wall of your artery, calcium must enter the cell. Calcium is the trigger for the squeeze. These drugs act as doormen. They stand at the calcium channels on the cell membrane and refuse entry. No calcium allowed. Without calcium flowing in, the smooth muscle of the artery cannot contract. It literally loses the ability to squeeze. It becomes flaccid and dilated. The pipe widens and the pressure drops. Visualize this effect. Imagine a tight, constricted fist slowly opening, finger by finger, until the hand is flat and relaxed. This is what calcium channel blockers do to your arteries. There is a fascinating nuance here. Some calcium channel blockers, called dihydropyridines, like amlodipine, only work on the blood vessels. They are pure vasodilators. Others, called non-dihydropyridines, like diltiazem, work on both the vessels and the heart. They slow the heart rate while also opening the pipes. The physician chooses the drug based on the specific needs of the patient's heart. We must also touch upon the risk. When you lower blood pressure too aggressively, the body fights back. This is called reflex tachycardia. Imagine you take a strong vasodilator. Your pressure drops suddenly. The brain panics. It thinks you are bleeding. So, it screams at the heart to beat faster to compensate. The patient takes a pill to relax, but their heart starts racing. This is why we often combine drugs, a vasodilator to open the pipes and a beta blocker to keep the heart calm, preventing the reflex. The management of hypertension is rarely a single battle. It is a long war. Most patients will eventually need 2 or 3 different drugs, working on different mechanisms to keep their numbers safe. We might use a diuretic to drain the fluid, an ACE inhibitor to block the hormonal squeeze, and a calcium channel blocker to relax the vessel wall. This is combination therapy. But beyond the chemistry, there is the lifestyle, the salt intake, the stress, the weight. The drugs are powerful tools, but they are working against the tide if the patient does not change the environment. Let these concepts settle. The equation, flow times resistance. The 4 families, diuretics, beta blockers, ACE inhibitors, and calcium channel blockers. The mechanism, unkinking the hose, turning down the faucet, slowing the pump. The goal, a soft, steady, low-pressure flow that nourishes the organs without damaging them. You have now mastered the pipes. You understand how we keep the pressure down. But we have mentioned the removal of fluid several times. We have hinted at the role of the kidney. It is time to give this organ its due respect. In our next lesson, we will go deeper into the filtration system. We will study the diuretics and the drugs used for heart failure. We will learn how to manipulate the water itself. Lesson 10. Diuretics and heart failure agents. In our last lesson, we examined the pressure in the pipes. We spoke of squeezing and relaxing the arteries. But as any plumber knows, pressure is not just about the width of the pipe. It is about the volume of the water flowing through it. Sometimes, to save the system, you must simply open the drain. Tonight, we study the management of fluid. We study the drugs that manipulate the volume of the blood and the strength of the heart. These are the diuretics and the heart failure agents. To understand these drugs, we must first visit the organ of filtration, the kidney. Visualize the kidneys not as solid organs, but as a dense forest of microscopic tubes. Each kidney contains 1 million of these tubes, called nephrons. The nephron is the functional unit of life's chemistry. It determines what stays in your body and what leaves. The process begins at the top of the nephron, in a tiny knot of blood vessels called the glomerulus. Blood flows into this knot under high pressure. The walls of the vessels act like a sieve. Water, salt, sugar, and waste are pushed out of the blood and into the tube. This fluid is called the filtrate. Now, imagine this fluid traveling down the long, twisting roller coaster of the nephron tubule. As it travels, the body realizes it has made a mistake. It has thrown away too much good stuff. It needs that water back. It needs that salt back. So, as the fluid moves down the tube, the cells lining the wall frantically grab the water and salt and pull them back into the blood. This is called reabsorption. Under normal circumstances, 99% of the water is reabsorbed. Only 1% becomes urine. Diuretics, commonly known as water pills, are drugs designed to sabotage this reabsorption process. They are chemical blockades. They operate on a single fundamental rule of physics: water follows salt. Sodium is magnetic to water. If the kidney pulls sodium back into the blood, water follows it, and blood volume stays high. If we can stop the kidney from grabbing the sodium, if we can keep the sodium in the tube, the water will stay in the tube to dilute it. The water then leaves the body as urine. Volume drops, pressure drops. We classify diuretics based on where in the nephron they block this sodium reabsorption. Let us start with the most powerful class, the loop diuretics. These drugs, such as furosemide, Lasix, work in a specific section of the tube called the loop of Henle. This is a deep dive into the center of the kidney. The loop of Henle is responsible for the bulk of salt reabsorption. When we block the pumps here, we stop a massive amount of sodium from returning to the blood. Because water follows salt, a massive amount of water stays in the urine. The effect is torrential. A patient can lose liters of fluid in a matter of hours. We call these high-ceiling diuretics because they are incredibly potent. We use them for acute situations when fluid is filling the lungs or when the legs are swollen with edema. They are the emergency drain. Next, we have the thiazide diuretics, like hydrochlorothiazide. These work further down the line, in the distal convoluted tubule. By this point in the tube, most of the sodium has already been reabsorbed, so blocking the pumps here has a milder effect. These are not for emergencies. These are the gentle, daily maintenance drugs used to treat high blood pressure. They lower the volume just enough to relax the arteries over the long term. However, there is a price to be paid for this drainage. When you force the kidney to excrete sodium and water, it often gets confused and throws away other precious minerals, specifically potassium. Hypokalemia, or low potassium, is a dangerous side effect of loop and thiazide diuretics. Potassium is the battery acid of the heart. If levels drop too low, the heart's electrical rhythm becomes unstable, leading to fatal arrhythmias. To solve this, we have a third class, potassium-sparing diuretics. The most famous of these is spironolactone. It works at the very end of the line, in the collecting duct. It works by blocking a hormone called aldosterone. Aldosterone is the body's salt-hoarding hormone. It tells the kidney, keep the sodium, throw away the potassium. Spironolactone acts as an antagonist. It blocks this message. The result is that sodium is thrown away, causing a mild diuretic effect, but potassium is kept. We often combine these drugs with the others to maintain a perfect electrolyte balance. Now, let us connect this fluid management to the condition of heart failure. Heart failure does not mean the heart has stopped. It means the heart is too weak to pump the blood forward efficiently. Imagine a weak pump trying to push water through a heavy hose. If it cannot push hard enough, the water backs up. In the human body, this backup happens in the lungs. Fluid leaks out of the blood vessels and fills the air sacs. The patient feels like they are drowning. This is congestive heart failure, CHF. Diuretics are the first line of defense. By reducing the volume of blood by draining the water, we reduce the workload on the heart. We lower the preload. Imagine taking some water out of the hose. Suddenly, the weak pump can move the remaining fluid much more easily. The backup clears. The patient can breathe again. But we can do more than just lighten the load. We can also try to strengthen the pump itself. This brings us to the cardiac glycosides, specifically a drug called digoxin. Digoxin has a romantic history. It is derived from the foxglove plant, Digitalis purpurea. For centuries, healers used it to treat dropsy, an old term for swelling. Digoxin works on the cellular level to increase the concentration of calcium inside the heart muscle cells. As we learned, calcium is the trigger for contraction. More calcium means a harder squeeze. We call this positive inotropy. It makes the heartbeat stronger. Simultaneously, digoxin stimulates the vagus nerve, the parasympathetic brake. This slows the heart rate down. We call this negative chronotropy. So, the net effect of digoxin is a heart that beats slower but stronger. It is a more efficient pump. It allows the heart to rest between beats while still moving enough blood to keep the patient alive. However, digoxin has a very narrow therapeutic index. The difference between the dose that strengthens the heart and the dose that stops the heart is tiny. In the paintings of Vincent van Gogh, you see glowing halos around the stars. Some historians believe he was suffering from digitalis toxicity, as one of the side effects is seeing yellow halos around lights. Today, treating heart failure is a delicate symphony. We use a loop diuretic to remove the fluid from the lungs. We use an ACE inhibitor to relax the arteries so the heart doesn't have to push so hard. We use a beta blocker to protect the heart from the stress of adrenaline. And occasionally, we use digoxin to strengthen the beat. Let these concepts flow through you like water. The nephron, the winding river of filtration. The rule, water follows salt. The loop diuretics, the heavy artillery for drainage. The thiazides, the gentle maintenance. The potassium-sparing agents, the balancers. And the failing heart, unburdened by the reduction in volume, beating slow and strong. You understand now that pharmacology is not just about adding chemicals, it is about subtraction. Sometimes, the best medicine is to help the body let go of what it is holding too tightly. Fluid balance is restored, the pressure is normalized, the breathing is easy. We have now completed our tour of the cardiovascular and renal systems. We have treated the heart, the vessels, and the kidneys. Now, we must ascend. We leave the trunk of the body and travel upward to the command center. In our next lesson, we will cross the blood-brain barrier. We will enter the complex, mysterious world of the central nervous system. We will study the drugs of sleep and anxiety. Lesson 11. Sedative-Hypnotic and Anxiolytic drugs. We have repaired the heart. We have cleansed the blood. We have balanced the fluids. Now, we leave the machinery of the body behind and ascend to the command center. We enter the skull. We enter the complex, electric world of the central nervous system. Tonight, we study the chemistry of peace. We study the drugs that quiet the noise, calm the fear, and induce the state you are drifting into right now. These are the sedative-hypnotics and the anxiolytics. To understand how to calm the brain, we must first understand why it is active. Imagine the brain as a vast city at night. Billions of windows are lit. In every window, a neuron is firing, sending an electrical signal. This electricity is the language of thought, of movement, of sensation. But sometimes, the city becomes too loud, the lights are too bright, the traffic is chaotic. This excess of electrical activity manifests as anxiety. If it persists into the night, it manifests as insomnia. If it explodes uncontrollably, it manifests as a seizure. To restore order, the brain relies on a system of inhibition. It needs an off switch. The primary operator of this switch is a neurotransmitter called GABA. That stands for gamma-aminobutyric acid. GABA is the master brake of the brain. When GABA is released, it tells the neurons to slow down. It tells the city to dim the lights. Let us look closely at the mechanism. The GABA receptor is a complex protein structure embedded in the neuron's membrane. It is a channel, a tunnel. When GABA binds to this receptor, the tunnel opens. Outside the cell, there is a high concentration of chloride ions. Chloride has a negative electrical charge. When the tunnel opens, these negative ions rush into the cell. This is a matter of physics. The inside of the neuron becomes more negative. In scientific terms, we say the cell becomes hyperpolarized. A hyperpolarized cell is a stubborn cell. It is far away from the threshold it needs to fire an electrical spark. It becomes difficult to excite. It ignores the noise outside. It goes to sleep. The drugs we discussed tonight, benzodiazepines and barbiturates, do not replace GABA. They do not force the door open themselves. Instead, they act as potentiators. They bind to the receptor alongside GABA and make it work better. They grease the hinges of the door. Let us begin with the most common class, the benzodiazepines. These are drugs with names you likely know: diazepam, Valium, alprazolam, Xanax, lorazepam, Ativan. They are the primary treatment for anxiety and panic. Benzodiazepines bind to a specific allosteric site on the GABA receptor. When they bind, they change the shape of the receptor slightly so that GABA can bind more easily. Specifically, they increase the frequency of the channel opening. The door opens more often. Because of this mechanism, benzodiazepines have a ceiling to their effect. They can only amplify the GABA that is naturally there. This makes them relatively safe compared to older drugs. They calm the mind, relax the muscles, and stop seizures. However, there is an older, more dangerous class of drugs, the barbiturates, like phenobarbital. These drugs bind to a different spot on the receptor. Instead of making the door open more often, they hold the door open for a longer duration. The channel stays wide open, flooding the cell with negative chloride. Because of this hold-open mechanism, barbiturates are much more powerful. At high doses, they can open the channel even without any GABA present. They don't need the natural brake. They simply shut down the system entirely. This makes them incredibly effective, but also lethal. It is very easy to stop the brain completely, including the part that tells you to breathe. This brings us to the concept of the sedative-hypnotic continuum. These drugs exist on a sliding scale of depression. It is the same drug, doing the same thing, but the effect changes based on the dose. At the lowest dose, we achieve anxiolysis. This is the relief of anxiety. The patient feels calm. The worry fades. The cognitive sharpness is slightly dulled, but they are awake. Increase the dose, and we achieve sedation. The patient becomes drowsy. Reaction times slow down. Physical coordination becomes clumsy. Increase the dose further, and we achieve hypnosis. This does not mean a trance. In pharmacology, it simply means sleep. The patient loses consciousness, but can be woken up. Increase the dose again, and we reach anesthesia. The patient is unconscious and cannot be woken up, even by pain. This is the state used for surgery. Finally, at the highest doses, we reach coma and death. The brainstem shuts down. Respiration stops. This continuum is why mixing these drugs with alcohol is so deadly. Alcohol is also a CNS depressant. It also works on the GABA receptor. If you take a benzodiazepine and drink alcohol, you are attacking the brain with two hammers at once. This is called synergism. 1 + 1 does not equal 2, it equals 10. The combined effect pushes the patient down the continuum toward death very rapidly. We must also discuss the brain's adaptation. The brain hates to be controlled. If you take a sleeping pill or an anxiety pill every day, the brain realizes that its off switch is being pressed too hard. To compensate, it tries to turn the volume up. It downregulates the GABA receptors, removing them, and upregulates the excitatory systems like glutamate. This is tolerance. Over time, you need a higher dose to get the same sleep. If you suddenly stop taking the drug, you are left with a brain that is wired for noise. The brake is gone, and the accelerator is stuck to the floor. The result is withdrawal. The symptoms are the exact opposite of the drug's effect. Instead of calm, there is panic. Instead of sleep, there is insomnia. Instead of muscle relaxation, there are tremors and seizures. This is why these medications should usually be short-term solutions. They are bridges to get a patient through a crisis, not a permanent place to live. There is one more specialized group of drugs in this category, the Z drugs, like Zolpidem, Ambien. These were designed to be more specific. While benzodiazepines hit receptors all over the brain affecting emotion, muscle tone, and memory, Z drugs try to target only the receptors involved in sleep. The goal is to knock the patient out without causing the other side effects. However, they still work on GABA, and they still carry risks of strange behaviors like sleepwalking or even sleep driving. Let these concepts settle into the darkness behind your eyes. The busy city of the brain, the lights dimming, GABA, the gentle librarian, shushing the noise. The chloride ions rushing in, bringing their negative charge to quiet the cell. The sliding scale, anxiety to sleep to coma. The danger of the combination. The need for balance. You are now experiencing the very effect we are studying. Your own GABA levels are rising. Your own cortical activity is slowing. The logical centers are dimming, allowing the memory centers to store this information. We have quieted the speed of the brain. But what about the mood of the brain? What about the chemistry of sadness or the chemistry of madness? In our next lesson, we will adjust the emotional thermostat. We will explore the drugs used to treat depression and schizophrenia. Lesson 12. Antidepressant and Antipsychotic Agents. In our last lesson, we learned how to slow the brain down using sedatives. We learned how to quiet the electrical noise of anxiety. But the human mind suffers from more than just speed. It suffers from darkness. It suffers from distortion. Tonight, we explore the pharmacology of emotion and perception. We enter the delicate world of mood disorders and psychosis. We will study the drugs that lift the veil of depression and the drugs that silence the voices of schizophrenia. These are the antidepressants and the antipsychotics. To understand these medications, we must look at a specific group of neurotransmitters called the monoamines. These are the chemical messengers of personality. There are three main characters in this story. First, there is serotonin. This is the molecule of satisfaction, of well-being, of okayness. It regulates sleep, appetite, and mood. Second, there is norepinephrine. This is the molecule of energy, focus, and drive. Third, there is dopamine. This is the molecule of reward, pleasure, and salience. It tells the brain what is important. For decades, the prevailing theory of depression has been the monoamine hypothesis. This theory suggests that depression is caused by a chemical deficiency, a lack of serotonin and norepinephrine in the synaptic gap between neurons. If the tank is empty, the machine cannot run. Therefore, the goal of pharmacology is to refill the tank. Let us visualize the mechanism of the most common class of drugs, the SSRIs, or selective serotonin reuptake inhibitors. These include famous names like fluoxetine, Prozac, and sertraline, Zoloft. Picture two neurons talking to each other. The first neuron releases a burst of serotonin into the gap, the synapse. The serotonin floats across the gap, hits the receptor on the second neuron, and delivers its message of happiness. But the body is efficient. It does not waste chemicals. As soon as the message is delivered, the first neuron turns on a vacuum cleaner. It has a transporter pump that sucks the serotonin back up to be recycled. This process is called reuptake. An SSRI works by jamming this pump. It blocks the reuptake transporter. Imagine putting a cap on the vacuum cleaner. The serotonin cannot be recycled. It is trapped in the gap. Because it has nowhere to go, it stays there, bouncing against the receptors of the second neuron again and again. The volume of the signal is amplified. The silence of depression is replaced by a sustained chemical note of well-being. We also have SNRIs, serotonin norepinephrine reuptake inhibitors. These block the recycling of both serotonin and the energy molecule, norepinephrine. These are often used when a patient is not just sad, but physically heavy, lethargic, and unable to get out of bed. They provide both mood and motive. But here lies a great mystery in pharmacology. When a patient takes an antidepressant, the chemical levels in their brain change within hours. The reuptake is blocked almost immediately. Yet, the patient does not feel better for 4 to 6 weeks. Why the delay? If it were just a simple fuel shortage, the engine should start immediately. This leads us to the concept of neuroplasticity. We now believe that depression is not just a lack of chemical juice, it is a structural withering of the brain. Under chronic stress, neurons in the hippocampus, the memory and emotion center, begin to shrink. They lose their connections. The brain literally atrophies. When we boost serotonin with drugs, we trigger a downstream production of a protein called BDNF, brain-derived neurotrophic factor. Think of BDNF as fertilizer for the brain. It takes weeks to work, but slowly, it stimulates the neurons to grow new branches. It repairs the wiring. So, the drug is not just masking the sadness, it is facilitating the physical rebuilding of the emotional circuitry. This is why patience is the most important part of the prescription. Now, let us turn to the other side of the lesson, antipsychotics. If depression is a loss of signal, schizophrenia can be viewed as an excess of signal, specifically an excess of dopamine. In the schizophrenic brain, there is a flood of dopamine in the mesolimbic pathway. This is the pathway of salience. Normally, this pathway helps you identify what is important, a red light, a familiar face. But when it is flooded, everything becomes significant. A license plate number feels like a secret code. A voice on the radio feels like a message from God. These are positive symptoms, hallucinations, and delusions. Antipsychotic drugs are designed to turn this noise down. They are dopamine antagonists. We divide them into 2 generations. The first generation, or typical antipsychotics, were developed in the 1950 seconds. Drugs like haloperidol are heavy hammers. They block the dopamine D2 receptor completely and powerfully. They silence the voices effectively. However, dopamine is also used in the part of the brain that controls movement. When you block dopamine there, you cause side effects that look like Parkinson's disease. The patient may develop tremors, stiffness, or a shuffling walk. These are called extrapyramidal symptoms. To solve this, scientists developed the second generation, or atypical antipsychotics. These include drugs like risperidone and quetiapine. These drugs are more like scalpels than hammers. They still block dopamine, but they do it more gently, and they dissociate from the receptor quickly. They allow just enough dopamine through to let the patient move normally, but not enough to let them hallucinate. They also block serotonin receptors, 5-HT2A, which helps balance the system further. While these newer drugs spare the patient the movement disorders, they carry their own burden. They often cause significant metabolic changes, weight gain, high blood sugar, and high cholesterol. The treatment of psychosis is often a difficult trade-off between mental clarity and physical health. Let us also consider the side effects of antidepressants, as they teach us about the body's map. Serotonin is not just in the brain. In fact, 90% of your serotonin is in your gut. It regulates the movement of your intestines. When a patient takes an SSRI, they boost serotonin in the brain, which improves mood, but they also boost it in the gut, which causes nausea and diarrhea. The side effect is simply the drug working in the wrong place. Similarly, dopamine inhibits the hormone prolactin. Prolactin produces breast milk. When we give an antipsychotic that blocks dopamine, the brake on prolactin is removed. This can cause patients, even men, to develop breast tissue and lactate. It is a reminder that these chemicals are used for many different purposes throughout the body. Let these concepts settle. The monoamine hypothesis, the tank is empty. The reuptake inhibitor, the cap on the vacuum cleaner. The delay, the time it takes for the brain to regrow its connections using BDNF. The dopamine hypothesis, the volume is too loud. The antagonist, the blocker that quiets the hallucinations. The trade-off, movement versus metabolism. These drugs have revolutionized humanity. Before their invention, patients with severe depression or psychosis were often locked away in asylums, untreated. Today, they live among us, working, loving, and functioning. These molecules are not just chemicals, they are keys that unlock the prison of the mind. You now understand the chemistry of the personality. You see how delicate the balance is between sorrow and joy, between reality and delusion. In our next lesson, we will move from the pain of the mind to the pain of the body. We will explore the sensation of physical suffering and how we silence it. We will study the opioids and the anti-inflammatories. Lesson 13. Opioid analgesics and NSAIDs. In our previous lesson, we balanced the chemistry of the mind. Now, we turn our attention to the most primal sensation of all, physical suffering. Pain is the body's oldest language. It is a warning system, essential for survival. It tells us that tissue is being damaged, that we must move, or that we must rest. But sometimes, the warning is too loud. Sometimes, the alarm continues long after the danger has passed. In these moments, we turn to pharmacology to sever the connection between injury and suffering. This is Lesson 13. Opioid analgesics and non-steroidal anti-inflammatory drugs. To understand pain relief, we must understand that pain is not a single event. It is a relay race. It begins at the site of injury, a cut finger, a broken bone where nerves detect damage. This signal travels up the spinal cord. It enters the brainstem. Finally, it reaches the cortex, where you consciously say, ouch. We have two main families of drugs to interrupt this race. One family works at the starting line, at the site of the injury. These are the NSAIDs. The other family works at the finish line, deep inside the brain. These are the opioids. Let us begin with the heavy artillery, the opioids. These drugs, morphine, codeine, oxycodone, fentanyl, are gifts from the poppy plant, Papaver somniferum. Humanity has cultivated them for thousands of years because they possess a unique ability. They do not just stop the sensation of pain, they stop the suffering associated with pain. The mechanism is elegant and powerful. Opioids work by mimicking your body's own natural painkillers, the endorphins. The word endorphin actually translates to endogenous morphine, morphine made from within. When you take an opioid, the drug molecules travel through the blood and cross the blood-brain barrier. They seek out specific locks called mu receptors. These receptors are found in high concentrations in the spinal cord and the brainstem. When the opioid binds to the mu receptor, two things happen at the cellular level. First, on the nerve that is trying to send the pain signal, the drug closes the calcium channels. Without calcium, the nerve cannot release its neurotransmitter. It cannot shout pain to the next nerve. The message is silenced before it is even spoken. Second, On the receiving nerve, the drug opens potassium channels. Potassium rushes out, making the cell negative and hard to excite. The result is a profound dampening of the signal, but the true magic happens in the emotional centers of the brain. A patient on morphine will often say, "I can still feel the pain, but it doesn't bother me." The drug has disconnected the sensation from the emotional reaction. It induces a state of euphoria, a sense that everything is fine. However, the mu receptor is a double-edged sword. It is also found in the brainstem, in the exact center that controls your automatic breathing. When you take too much opioid, you do not just stop the pain, you stop the drive to breathe. This is respiratory depression, and it is the cause of death in overdose. The patient simply forgets to inhale. Furthermore, the brain adapts quickly. It builds tolerance, requiring higher doses to get the same relief. And it develops dependence, meaning that if you stop the drug, the body crashes into withdrawal, a flu-like state of agony that is the mirror image of the drug's comfort. Now, let us move away from the brain and travel to the site of the injury. Let us look at the NSAIDs. This stands for non-steroidal anti-inflammatory drugs. The most common examples are aspirin, ibuprofen, Advil, and naproxen, Aleve. These drugs do not affect your mood. They do not cause euphoria. Instead, they are molecular mechanics working on the damaged tissue itself. To understand them, you must visualize the arachidonic acid cascade. When a cell is damaged, its membrane is broken. A fatty acid called arachidonic acid is released. This acid is immediately grabbed by an enzyme called cyclooxygenase, or COX. Think of the COX enzyme as a factory worker. It takes the acid and twists it into a new shape, creating a family of chemicals called prostaglandins. Prostaglandins are the messengers of inflammation. They cause three things: swelling, edema, fever, heat, and increased sensitivity to pain. They make the nerve endings raw and tender, so that even a light touch hurts. NSAIDs work by inhibiting the COX enzyme. They shut down the factory. If the COX enzyme is blocked, no prostaglandins are made. If no prostaglandins are made, the swelling goes down, the fever breaks, the nerve endings calm down, the pain vanishes at the source. However, there is a catch. The body has two types of this enzyme, COX-1 and COX-2. COX-2 is the bad enzyme that appears only during injury to cause inflammation. But COX-1 is a good housekeeping enzyme. It is always working. Its job is to produce a protective mucus layer in the stomach, shielding the stomach lining from its own acid. Shutterstock. Traditional NSAIDs, like ibuprofen, are non-selective. They act like a shotgun, destroying both COX-1 and COX-2. So, while you get pain relief by blocking COX-2, you also lose the protective lining of your stomach by blocking COX-1. This is why chronic use of NSAIDs leads to gastric ulcers and stomach bleeding. It is a trade-off between the joint and the gut. Scientists tried to solve this by creating COX-2 inhibitors, like celecoxib. These drugs were designed to be snipers, hitting only the inflammation enzyme and sparing the stomach. They worked, but they revealed a dark surprise. They increased the risk of heart attacks. It turns out, we need a balance of these enzymes for healthy blood clotting. There is one final drug that stands alone: acetaminophen, Tylenol. It is not an opioid. It is not an NSAID. It reduces pain and fever, but it does not reduce inflammation. If you have a swollen ankle, Tylenol will numb the pain, but the ankle will remain the size of a grapefruit. Its mechanism is still somewhat mysterious, believed to work centrally in the brain. Its danger is not to the stomach, but to the liver. In high doses, it produces a toxic metabolite that can destroy the liver overnight. It is the most common cause of acute liver failure in the Western world. Let this landscape of pain management settle in your mind. The opioid, the central silencer, the disconnection of emotion, the risk of the breath stopping, the key to the mu receptor, the NSAID, the peripheral mechanic, the stopper of inflammation, the inhibitor of prostaglandins, the risk to the stomach lining, the acetaminophen, the gentle fever reducer with the toxic shadow. Pain management is the art of balancing these risks. We use the NSAID for the sprained ankle. We use the opioid for the broken femur. We combine them to attack the pain from both ends of the wire, silencing the source and numbing the receiver. You now understand how we defend the body from its own signals. We've quieted the internal alarm. But the body faces threats from the outside as well. We are surrounded by invisible living enemies. In our next lesson, we will turn our defenses outward. We will pick up the weapons of biological warfare. We will study the drugs that kill living things. Lesson 14. Antimicrobial Agents. In all our previous lessons, we have discussed drugs that act upon you, drugs that change human cells to restore human health. But tonight, we face a different challenge. Sometimes, the threat does not come from within, it comes from without. We live in a microbial world. We are surrounded by invisible living organisms that seek to inhabit us. When they succeed, we call it infection. To treat infection, we cannot use the rules of human physiology. We must turn our pharmacological weapons against a foreign invader. We must kill the alien without harming the host. This is the principle of selective toxicity. It is the most delicate sniper shot in medicine. This is Lesson 14, Antimicrobial Agents. To understand how antibiotics work, we must first appreciate the target, the bacterium. Bacteria are prokaryotes. They are ancient, simple, single-celled organisms. They are fundamentally different from human cells, which are eukaryotes. These structural differences are the chinks in their armor. They are the specific targets we aim for. We generally classify antibiotics by which part of the bacterial anatomy they destroy. There are three main targets: the wall, the factory, and the blueprint. Let us begin with the most famous target, the cell wall. Human cells are soft. We are held together by a thin, flexible membrane. Bacteria, however, are under immense internal pressure. To keep from exploding, they are encased in a rigid, mesh-like shell made of a substance called peptidoglycan. This wall is their shield. The first and greatest family of antibiotics, the beta-lactams, targets this wall. This family includes penicillin, discovered by Alexander Fleming in 1928, and its modern cousins, the cephalosporins. Visualize the bacteria trying to build this wall. It is like laying bricks. The bacteria use an enzyme, often called a penicillin-binding protein, to apply the mortar that sticks the bricks together. Penicillin works by jamming this enzyme. It steals the mortar. The bacteria continues to grow, but the wall is weak. It has holes in it. Eventually, the internal pressure becomes too great for the structural integrity of the shell. The bacterium literally bursts open. It explodes. This is a bactericidal effect. It is a violent, definitive death for the invader. However, not all bacteria are the same. We divide them into two great empires, gram-positive and gram-negative. Gram-positive bacteria have a thick, exposed wall. They are easy targets for penicillin. Gram-negative bacteria are more armored. They have a second, outer membrane protecting their wall. To kill them, we need drugs that are more like armor-piercing rounds, capable of navigating that outer defense. Now, let us move to the second target, the factory, or protein synthesis. Every living cell needs to make proteins to survive. Proteins are the machines of life. They are built by tiny organelles called ribosomes. Here is the key to selective toxicity. Bacterial ribosomes and human ribosomes are different sizes. Bacterial ribosomes are 70S, while humans are 80S. Because of this difference, we can design drugs that jam the gears of the bacterial factory while leaving the human factory running smoothly. There are several classes of drugs that do this. The macrolides, like azithromycin, Z-Pak, bind to the ribosome and stop the protein chain from growing. The tetracyclines block the arrival of new building materials. The aminoglycosides cause the factory to misread the instructions, creating garbled, useless proteins. These drugs are often bacteriostatic. They do not always kill the bacteria directly. Instead, they freeze them. They stop them from growing and reproducing. They hold the enemy still so that your own immune system, the white blood cells, can come in and finish the job. It is a partnership between the drug and your body. Finally, we target the blueprint, or DNA replication. Bacteria reproduce with terrifying speed. To do this, they must copy their DNA constantly. Bacterial DNA is a tightly coiled double helix. To copy it, they must uncoil it, read it, and coil it back up. They use an enzyme called DNA gyrase, or topoisomerase, to manage this twisting and untwisting. We have a class of drugs called fluoroquinolones, such as ciprofloxacin. These drugs attack DNA gyrase. They jam the zipper. When the bacteria tries to uncoil its DNA to reproduce, the DNA snaps. The genetic code is shattered. The bacteria cannot reproduce, and it dies. There is a fourth, rarer target: metabolism. Bacteria need folic acid to survive, just like we do. Humans simply eat folic acid in our diet. Bacteria, however, must build it from scratch. Sulfonamides, sulfur drugs, mimic the building blocks of folic acid. The bacteria try to build with them, but the product is fake. The bacteria starves to death from a lack of nutrients, while the human host is unaffected because we get our vitamins from food. But this story has a dark side. We are in an evolutionary arms race. Bacteria are not passive victims. They evolve. They share secrets. When we use antibiotics too often, or incorrectly, we teach the bacteria how to survive. This is antibiotic resistance. Some bacteria have learned to produce an enzyme called beta-lactamase. This enzyme acts like a pair of scissors. When the penicillin molecule approaches, the bacteria sends out this enzyme to cut the drug in half before it can touch the wall. The drug is neutralized. To fight this, we have begun adding decoys to our pills. For example, Augmentin is a combination of amoxicillin, the drug, and clavulanate, the decoy. The bacterial scissors attack the decoy, leaving the antibiotic free to kill the cell. Other bacteria have learned to change the shape of their ribosomes so the drug cannot attach. Some have even built pumps, efflux pumps, that physically bail the antibiotic out of the cell as fast as it enters. This is why the practice of pharmacology is also a practice of stewardship. These drugs are a finite resource. If we use them when they are not needed for a viral cold, for example, we are simply training our enemies. We are dulling our weapons. Let this final concept settle. The fragility of the bacterial wall, the precision of the ribosomal inhibition, the shattering of the DNA, and the constant, silent war between the drug and the evolving resistance. You have now completed the course. Think back to where we began. We started with a single receptor, a lock, and a key. We traveled through the blood, calculating the half-life and the dose. We watched the liver metabolize and the kidney excrete. We learned how to slow the heart, relax the vessel, and drain the lung. We learned how to quiet the anxious mind, lift the depressed spirit, and silence the screaming nerve. And finally, we learned how to defend the fortress against the invisible invasion. The body is a masterpiece of biological engineering. Pharmacology is simply the toolkit we use to maintain it. It is not magic. It is logic. It is chemistry. And now, that logic is a part of you. Lesson 15. Endocrine Pharmacology. Diabetes and Thyroid. In our previous lessons, we explored the nervous system, where signals travel like lightning along a wire. A nerve fires, and a muscle twitches instantly. But the body has another way of communicating. It has a wireless system. It has a system of slow chemical tides that regulate growth, metabolism, and energy over hours, days, and years. This is the endocrine system. Tonight, we study the pharmacology of hormones. We will focus on the two most common metabolic disorders in human health: the regulation of sugar, which is diabetes, and the regulation of energy, which is the thyroid. Let us begin with the pancreas. Deep in your abdomen, behind the stomach, lies this organ. It has a dual nature. Part of it helps digest food, but scattered throughout it are tiny islands of cells called the islets of Langerhans. These islands monitor your blood. They taste the sweetness of your circulation. When you eat a meal and sugar glucose enters your blood, these islands release a hormone called insulin. You must understand what insulin is. It is a key. Every cell in your body needs glucose for fuel, but glucose cannot just walk through the cell wall. It is too big. The cell wall has locked doors, transporter channels. Insulin floats through the blood, attaches to the cell, and unlocks these doors. The doors open, and the sugar rushes in to be burned for energy. The level of sugar in the blood drops, and the cells are fed. Diabetes mellitus is a failure of this system. It comes in two distinct forms, and the pharmacology for each is different. Type 1 diabetes is a tragedy of the immune system. The body's own defenses attack the pancreas and destroy the insulin-producing cells. The keys are gone. The patient has plenty of sugar in their blood, starvation in the midst of plenty, but the cells are locked shut. The treatment here is simple but vital: insulin replacement. We must inject the hormone that the body can no longer make. We have engineered different types of insulin to mimic the body's natural rhythm. We have rapid-acting insulin, which works in minutes, taken right before a meal to handle the spike in food. And we have long-acting insulin, which releases slowly over 24 hours, providing a background level of control, just like a healthy pancreas does while you sleep. Type 2 diabetes is different. It is a disease of resistance. The pancreas is making keys. It might even be making too many keys. But the locks on the cells are rusty. They are jammed. We call this insulin resistance. The insulin binds, but the door doesn't open. The pancreas works harder and harder, screaming to be heard, until it eventually burns out. The first-line drug for type 2 diabetes is a masterpiece of pharmacology called metformin. Metformin does not give you more insulin. Instead, it works primarily on the liver. You see, the liver is a sugar factory. When you are fasting, the liver makes glucose to keep you alive. In type 2 diabetes, the liver gets confused and overproduces sugar, dumping it into the blood, even when you don't need it. Metformin tells the liver to stop. It shuts down the factory. Simultaneously, it resensitizes the muscle cells to the insulin that is already there. It greases the rusty locks. Because metformin does not squeeze the pancreas to release more insulin, it rarely causes hypoglycemia, low blood sugar. This makes it incredibly safe. It is the anchor of diabetic treatment. We also have drugs that do squeeze the pancreas, called sulfonylureas, like glipizide. These drugs bind to the beta cells and force them to release more insulin. They are effective, but they carry the risk of driving blood sugar too low, a condition where the brain starves of fuel, leading to confusion and fainting. In recent years, we have discovered a new pathway involving the incretin hormones. These are signals released by the gut when you eat. They tell the pancreas, "Food is coming, get ready." Drugs like semaglutide mimic this signal. They boost insulin, but they also slow down the stomach, making the patient feel full. This causes weight loss, which is often the most effective cure for the insulin resistance itself. Now, let us shift our focus upward, to the neck, to the thyroid gland. If the pancreas controls fuel, the thyroid controls the speed at which you burn it. It is the metabolic thermostat. It is shaped like a butterfly wrapped around your windpipe. It produces hormones T3 and T4 that travel to the nucleus of every cell in your body and tell the DNA to speed up protein production and burn oxygen. We encounter two problems here. The thermostat is too low or the thermostat is too high. Hypothyroidism is when the gland is underactive. The fire is dying. The patient feels cold, tired, and slow. They gain weight. Their heart beats slowly. Their hair becomes brittle. The treatment is levothyroxine. This is synthetic T4. We are simply replacing what is missing. The goal is to return the body to a euthyroid state, a state of normal function. It is a delicate balance. If we give too little, the patient remains sluggish. If we give too much, we induce a state of artificial anxiety and heart palpitations. This balance is monitored by a feedback loop involving the brain. The pituitary gland in the brain tastes the blood. If thyroid hormone is low, the pituitary screams a command called TSH, thyroid stimulating hormone. Therefore, a high TSH means the thyroid is failing, the boss is shouting because the worker is sleeping. When we give levothyroxine, the TSH level drops back to normal. The boss stops shouting. Hyperthyroidism is the opposite. The gland is hyperactive. The fire is raging. The patient is hot, sweating, and losing weight rapidly. Their heart races. Their hands shake. They are in a state of constant, exhausted arousal. This is often caused by Graves' disease, where antibodies accidentally turn the thyroid switch to on permanently. To treat this, we use thioamides, like methimazole. These drugs inhibit the enzyme that builds thyroid hormone, thyroid peroxidase. They stop the production line. By blocking the synthesis of new hormone, we allow the body's levels to slowly drift down. Sometimes, drugs are not enough. We might use radioactive iodine. Because the thyroid is the only organ in the body that uses iodine, if we feed the patient radioactive iodine, it goes straight to the gland and destroys it from the inside, sparing the rest of the body. It is a precise surgical strike using physics instead of a scalpel. After the gland is destroyed, the patient becomes hypothyroid and must take levothyroxine for the rest of their life. Let these concepts settle. The pancreas as the gatekeeper of fuel. Insulin as the key. Type 1 as the missing key. Type 2 as the broken lock. Metformin as the liver's stop sign. The thyroid as the thermostat. Hypothyroidism as the dying fire. Levothyroxine as the fuel. Hyperthyroidism as the raging inferno. Thioamides as the water. The endocrine system teaches us that health is not a static state. It is a dynamic equilibrium. It is a constant, gentle oscillation of chemicals maintaining the perfect temperature, the perfect sugar level, the perfect energy. You are now in balance. Your sugar is stable. Your metabolism is slow and efficient. In our next lesson, we will look at another system that relies on flow and pressure. We will look at the breath. We will study the drugs that keep the airways open. Lesson 16. Respiratory Pharmacology. In our previous lesson, we studied the slow chemical tides of the endocrine system. We spoke of hormones that regulate your energy over days and weeks. Tonight, we turn to a rhythm that is immediate. We turn to the breath. Inhale and exhale. This cycle happens 12 to 20 times every minute, 20,000 times a day. It is the most vital rhythm of life. It is the exchange of gases that allows the fire of metabolism to burn. When this rhythm is broken, when the airways tighten and the air cannot flow, it is one of the most terrifying sensations a human being can experience. Tonight, we study the drugs that keep the airways open. We study respiratory pharmacology. To understand how we treat the lungs, we must first visualize the architecture of the respiratory tree. Imagine your lungs as an upside-down oak tree. The trunk is the trachea, the windpipe. It divides into two large branches, the bronchi. These divide into smaller and smaller branches, the bronchioles, until they end in microscopic clusters of leaves. These leaves are the alveoli, tiny air sacs where oxygen enters the blood and carbon dioxide leaves it. Wrapping around these branches, like vines on a tree, are bands of smooth muscle, and lining the inside of the hollow branches is a mucous membrane. In diseases like asthma and chronic obstructive pulmonary disease, or COPD, two distinct things go wrong with this architecture. First, the smooth muscle vines squeeze tight. This is bronchoconstriction. Second, the inner lining becomes swollen and inflamed, filling the tube with thick mucus. This is inflammation. The airway becomes a thin, clogged straw. Pharmacology must address both of these problems. We need openers and we need calmers. We need bronchodilators and we need anti-inflammatories. Let us begin with the openers, the bronchodilators. The most famous drug in this class is albuterol. To understand how it works, recall our lesson on the sympathetic nervous system. When a tiger chases you, your body releases adrenaline. Adrenaline binds to beta-2 receptors in the lungs. This signal tells the smooth muscle vines to relax, instantly widening the airway so you can run. Albuterol is a beta-2 agonist. It is synthetic adrenaline designed specifically for the lungs. When a patient inhales albuterol, the molecules fly down the bronchial tree and land on the beta-2 receptors of the smooth muscle cells. This triggers a cascade inside the cell. The receptor activates an enzyme called adenylyl cyclase, which increases a substance called cyclic AMP. Cyclic AMP is a messenger that tells the muscle fibers to let go. The squeeze releases, the airway snaps open. The relief is almost instant. This is why we call albuterol a rescue inhaler. It is for the emergency. However, albuterol has a short duration. It works for about 4 hours. For patients who need coverage all day and night, we use long-acting beta-agonists, or LABAs, like salmeterol. These molecules are lipophilic. They love fat. They dissolve into the membrane of the lung cells and slowly leak out over 12 to 24 hours, keeping the airway open while the patient sleeps. But there is another way to open the lung. We can approach it from the other side of the nervous system. Recall that the parasympathetic system, the rest and digest system, uses the vagus nerve to constrict the airways slightly. It uses the chemical acetylcholine. If we block this chemical, the airway relaxes. These drugs are the anticholinergics, also known as muscarinic antagonists. A common example is ipratropium. Think of the airway tone as a tug-of-war between the sympathetic system trying to open it and the parasympathetic system trying to close it. A beta-agonist pulls on the open side. An anticholinergic cuts the rope on the close side. Both result in a wider path for the air. Because anticholinergics also dry up secretions, remember dry as a bone, they are particularly useful in COPD, where patients suffer from wet, mucus-filled coughs. Now, we must address the second villain, inflammation. You can open the muscle all you want, but if the walls of the tube are swollen and thick, the air still cannot pass. This is where the corticosteroids enter the story. Drugs like fluticasone and budesonide are not rescue drugs. If you are having an asthma attack, a steroid inhaler will not save you in the moment. It takes too long. These are maintenance or controller drugs. Steroids work by entering the cells of the airway lining and traveling all the way to the nucleus. They interact with the DNA itself. They turn off the genes that produce inflammatory signals like cytokines, and turn on the genes that produce anti-inflammatory proteins. This is a slow, deep repair. It is like fixing the foundation of a house rather than just opening the window. Over days and weeks of use, the swelling in the bronchial walls goes down. The mucus production stops. The airway becomes less twitchy and less reactive to allergens. However, putting steroids into the body carries risks. If you take them as a pill, they suppress the entire immune system, cause weight gain, and thin the bones. This is why we prefer inhaled corticosteroids. By breathing the drug directly onto the lung tissue, we keep the effect local. We treat the organ without dosing the whole body. There is one specific side effect of inhaled steroids to visualize. Because they suppress the immune system locally in the mouth and throat, a fungus called Candida can overgrow. This is called thrush. It manifests as white patches on the tongue. We teach patients to rinse their mouth with water after every dose to wash away the residue and prevent this fungal bloom. Finally, we have a third pathway involving the leukotrienes. Leukotrienes are inflammatory chemicals released by immune cells called mast cells during an allergic reaction. They are potent constrictors thousands of times more powerful than histamine. If a patient has asthma that is triggered by allergies by cat dander, pollen, or dust, we often use a leukotriene receptor antagonist like montelukast, singular. This is a pill, not an inhaler. It blocks the specific chemical signal of the allergy, preventing the lung from reacting to the environment. So, let us synthesize this into a clinical picture. The management of respiratory disease is usually a step-up approach. Step 1 is the rescue inhaler, the blue puffer, the albuterol. This is kept in the pocket for emergencies. If the patient only has symptoms once a month, this is all they need. Step 2 is the controller, the brown or orange puffer, the inhaled steroid. If the patient is using their rescue inhaler too often, it means the inflammation is uncontrolled. We add the steroid to calm the fire. They take this every morning and night, regardless of how they feel. Step 3 is combination therapy. We put a steroid and a long-acting beta agonist in the same device. We attack the swelling and the constriction simultaneously, 24 hours a day. The goal of respiratory pharmacology is silence. A healthy lung is a quiet lung. It moves air without a wheeze, without a cough, without effort. As you lie there now, bring your attention back to your own breathing. Feel the cool air entering your nose, passing down the trachea, filling the bronchial tree, and expanding the alveoli. Visualize the beta-2 receptors on your smooth muscles gently activated, keeping the tubes relaxed. Visualize the absence of inflammation, the thin, healthy walls of your airways. The oxygen crosses into the blood effortlessly, carried by hemoglobin to every cell that needs it. The carbon dioxide leaves effortlessly, carrying away the waste. The cycle is perfect. The rhythm is unbroken. Inhale, peace. Exhale, tension. You have now mastered the breath. You understand how we keep the channel of life open. In our next lesson, we will follow the path of the swallow. We will descend below the diaphragm to the organ of digestion. We will study the stomach, the acid, and the chemistry of the gut. Lesson 17. Gastrointestinal Pharmacology. You are descending deeper into the body. You have left the airy chambers of the lungs. You have followed the esophagus down through the diaphragm, and now you have arrived at the body's central chemical reactor. You are in the abdomen. Tonight, we study the pharmacology of the gut. Specifically, we focus on the stomach, an organ designed to contain one of the most corrosive substances in nature and the mechanisms we use to tame it. This is Lesson 17, Gastrointestinal Pharmacology. To understand the drugs we use here, you must first respect the environment. The human stomach is a cauldron of hydrochloric acid. This acid is necessary. It sterilizes the food we eat, killing bacteria before they can enter the blood. It also activates the enzymes that break down proteins. Without it, we could not digest a meal. But this acid is dangerous. It has a pH of roughly 2, which is strong enough to dissolve metal. The only reason the stomach does not digest itself is because it is lined with a thick, protective layer of mucus. However, sometimes the system fails. Sometimes the valve at the top of the stomach, the lower esophageal sphincter, becomes weak. The acid splashes up into the esophagus, which has no protective lining. This burns the tissue, causing the sensation we call heartburn, or gastroesophageal reflux disease, GERD. Or sometimes, the mucus layer in the stomach is breached, allowing the acid to eat a hole in the wall. This is a gastric ulcer. To treat these conditions, we must lower the acidity. We must turn down the heat in the cauldron. To do that, we have to look at the microscopic pumps that produce the acid. Deep in the lining of the stomach wall, there are specialized cells called parietal cells. These cells have a pump on their surface called the H+, K+, ATPase. We simply call it the proton pump. This pump grabs potassium from the stomach and swaps it for a hydrogen ion, a proton, throwing the acid out into the chamber. This is the final step of acid secretion. No matter what triggered the stomach to work, the proton pump is the machine that actually does the job. We have two main classes of drugs to control this process. The older class is the H2 receptor antagonists. You know these as famotidine, Pepcid, or cimetidine, Tagamet. To understand them, you must know that the parietal cell has a receptor for histamine on its back door. When histamine binds to this receptor, it tells the cell, please make some acid. An H2 blocker stands in front of this door. It stops the histamine signal. The cell stops receiving the order, so it makes less acid. Notice I said less, not none. This is because there are other signals like gastrin and acetylcholine that can still tell the cell to work. H2 blockers are like turning down the volume knob, but they don't mute the system entirely. They are excellent for mild indigestion. But for severe reflux or ulcers, we need total control. We need the proton pump inhibitors, or PPIs. These are the drugs ending in prazole, like omeprazole, Prilosec, or pantoprazole. These drugs do not bother with the messenger at the back door. They go straight to the front line. They bind directly to the proton pump itself and jam it. They destroy the machine. Once a PPI binds to a pump, that pump will never work again. This is why PPIs are so powerful. They shut down acid production almost completely up to 99%. They allow the inflamed tissue of the esophagus or the ulcer to heal in peace without being bathed in acid. However, we must remember the principle of balance. Acid is there for a reason. If you suppress acid for years, you change the ecology of the gut. First, you lose a barrier against infection. Patients on long-term PPIs have a slightly higher risk of pneumonia and intestinal infections like C. difficile because the acid isn't there to kill the bugs. Second, you affect absorption. Many nutrients require an acidic environment to be absorbed. Calcium needs acid to dissolve. Long-term use of these drugs is linked to bone fractures because the body cannot absorb enough calcium. Vitamin B12 also requires acid. Over time, patients can become anemic or develop nerve damage if this deficiency isn't monitored. So, while these drugs are miraculous healers, the goal should always be to use the lowest dose for the shortest time necessary. Now, let us turn our attention to the second major function of GI pharmacology, the control of nausea and vomiting. Vomiting, or emesis, is a protective reflex. It is the body's ejection seat. If you eat a poisonous berry, the body needs to expel it immediately. But this reflex is controlled by a specific center in the brainstem called the chemoreceptor trigger zone, or CTZ. The CTZ is unique. It sits outside the blood-brain barrier. It tastes the blood directly, looking for toxins. Unfortunately, many medical treatments, like chemotherapy or anesthesia, look like toxins to the CTZ. The brain pulls the lever, and the patient becomes violently ill. To stop this, we use antiemetics. The gold standard in modern medicine is the serotonin 5-HT3 antagonist. The famous drug here is ondansetron, Zofran. It turns out that most of the serotonin in your body is not in your brain, it is in your gut. When cells in the gut are damaged by chemotherapy or a virus, they release a massive burst of serotonin. This serotonin hits the vagus nerve, which screams up to the brain, toxic, eject. Ondansetron blocks this specific receptor. It cuts the phone line. The gut releases the serotonin, but the vagus nerve never sends the signal. The brain remains calm. The patient does not vomit. We also have dopamine antagonists, like prochlorperazine. These work directly on the CTZ in the brain, blocking the dopamine receptors that trigger the nausea reflex. While effective, they carry the same risks as the antipsychotics we studied earlier, muscle twitches and sedation, because they are blocking dopamine in the brain. Finally, we have drugs that help things move down rather than up. Sometimes, the stomach simply falls asleep. This happens in diabetes, gastroparesis, or after surgery. The food sits there, causing nausea. We use prokinetic agents, like metoclopramide. This drug sensitizes the gut to acetylcholine. Recall that acetylcholine is the fuel of the rest and digest system. By boosting this signal, the drug forces the stomach to contract and push the food forward into the intestine. It unblocks the traffic jam. Let this complex factory settle in your mind. The stomach, the acid cauldron, the parietal cell, the worker, the proton pump, the machine, the H2 blocker, the gentle volume knob, the PPI, the master switch that jams the gears. The trade-off, healing the ulcer versus absorbing the calcium. The CTZ, the guardian tasting the blood for poison. The ondansetron, the silence that stops the ejection. You understand now that digestion is not just a mechanical churning, it is a chemical negotiation. We protect the lining by controlling the acid. We protect the comfort by controlling the nausea. We have now treated the gut. We have soothed the fire. But there is a fire that is much harder to control. A fire of cellular replication that knows no bounds. In our next lesson, we will face the most aggressive drugs in the pharmacopoeia. We will enter the war against cancer. We will study chemotherapy. Lesson 18. Cancer chemotherapy and antineoplastics. In our previous lesson, we soothed the fire of the stomach. We spoke of protecting the lining and controlling the acid. But tonight, we must face a fire that burns with a different intensity. We must face the fire of life itself, growing out of control. Tonight, we study the pharmacology of oncology. We study cancer chemotherapy. This is perhaps the most philosophically difficult challenge in medicine. When we treat an infection, we are killing a bacteria, a foreigner, an alien. But cancer is not a foreigner. Cancer is you. It is your own cells, your own DNA, which has forgotten how to stop growing. The challenge of chemotherapy is to kill the part of you that is trying to kill you, without destroying the rest of you in the process. We call this the principle of selective toxicity, but in cancer, the selection is razor thin. To understand how these drugs work, we must look at the engine of the disease, the cell cycle. Every cell in your body has a life cycle. It rests, it grows, it copies its DNA, and it divides. Cancer is a disease where the rest phase is broken. The cell is stuck in a loop of constant reproduction. Pharmacologists have designed drugs to sabotage specific gears in this machine. We classify chemotherapy based on where in the cycle it strikes. Let us begin with the S phase, or synthesis phase. This is the moment when the cell is trying to copy its DNA code to make a second set of chromosomes. To do this, it needs building blocks nucleotides. We have a class of drugs called antimetabolites. These are the spies and saboteurs. They look exactly like the natural building blocks of DNA, but they are fakes. Consider the drug methotrexate. It mimics folic acid. The cancer cell, hungry and rapidly dividing, grabs the methotrexate and tries to use it to build DNA. But the drug is a dud. It jams the enzyme. The DNA synthesis stops. The cell, realizing it cannot copy its code, triggers a self-destruct sequence called apoptosis. It is a death by deception. Next, we have drugs that do not care what time it is. They work in any phase of the cycle. These are the alkylating agents. The most famous is cyclophosphamide. These drugs are brute force weapons. They work by chemically attacking the DNA strands themselves. Imagine the double helix of DNA as a zipper. To read the code, the zipper must open. Alkylating agents act like superglue. They form strong bridges between the two sides of the zipper, locking it shut. When the cancer cell tries to read its instructions or copy itself, it finds the DNA is glued together. It shreds the DNA in frustration and dies. These drugs are powerful, but they are also blunt instruments, damaging healthy DNA alongside the cancer. Now, let us move to the final, dramatic act of the cell cycle, mitosis. This is the M phase, where the cell physically pulls itself apart into two new cells. Shutterstock explore. To do this, the cell builds a scaffold of microscopic tubes called microtubules. These tubes act like ropes. They latch onto the chromosomes and pull them to opposite sides of the room before the cell splits. We have a class of drugs called microtubule inhibitors. Some, like the vinca alkaloids, vincristine, prevent the ropes from being built. The cell tries to divide, but has no mechanism to pull the chromosomes apart. Others, like the taxanes, paclitaxel, prevent the ropes from breaking down. They freeze the scaffold in place. The cell is paralyzed in mid-division, unable to finish the job. In both cases, the result is the same. The division fails, and the cell dissolves. However, the tragedy of chemotherapy lies in its side effects. Most of these drugs cannot tell the difference between a cancer cell and a healthy cell. They only know one rule: attack anything that is dividing fast. Unfortunately, you have healthy tissues that divide fast to keep you alive. Your hair follicles divide rapidly. Chemotherapy attacks them, and your hair falls out. The lining of your mouth and gut divides rapidly, replacing itself every few days. Chemotherapy attacks it, causing painful sores, nausea, and diarrhea. Your bone marrow divides rapidly to make new blood cells. Chemotherapy attacks it, leading to a drop in white blood cells, risk of infection, red blood cells, anemia, and platelets, bleeding. We call this the nadir, the low point. It is the moment, usually 7 to 10 days after a dose, when the patient's defenses are at their absolute weakest. The art of oncology is dosing the drug just high enough to kill the cancer, but pausing just in time to let the bone marrow recover before the next dose. It is a rhythmic poisoning. In recent years, we have tried to move away from this carpet bombing approach towards sniper shots. This is the era of targeted therapy. Scientists realize that cancer cells often have specific mutations, broken switches that healthy cells do not have. For example, in certain types of leukemia, there is a specific enzyme called the tyrosine kinase that is stuck in the on position. It screams, "Grow," 24 hours a day. We developed a drug called imatinib, Gleevec. This drug is a small molecule designed to fit perfectly into that specific broken enzyme. It turns the switch off. Because healthy cells do not have this broken switch, the drug ignores them. The cancer dies, and the patient keeps their hair. We also use monoclonal antibodies. These are artificial immune system proteins. You can recognize them because they end in mab, like trastuzumab, Herceptin, or rituximab. Trastuzumab is used for breast cancers that overexpress a certain receptor called HER2. The drug acts like a flag. It attaches to the cancer cell and waves to the patient's own immune system, saying, "Here it is, attack this one." It recruits the body's own defenses to finish the job. Despite these advances, the cancer cell is a formidable opponent. It evolves. Just as bacteria develop antibiotic resistance, cancer cells develop chemoresistance. They learn to pump the drug out. They learn to fix the DNA glue. They learn to bypass the blocked enzymes. This is why we almost always use combination therapy. We attack with an antimetabolite, an alkylating agent, and a microtubule inhibitor all at once. We cut off the supply lines, glue the zipper, and cut the ropes simultaneously. We try to overwhelm the cancer's ability to adapt. Let this battle settle in your mind. The cell cycle, the clock of life. The S phase, the building of the code. The M phase, the pulling apart. The collateral damage to the hair and the gut. The precision of the targeted switch. You are witnessing the limits of human biology and the brilliance of human ingenuity. We are learning to edit the errors in our own code. As you sleep, visualize your own cells. They are orderly. They obey the signals. They divide only when needed. They rest when told. There is no chaos here. There is only the quiet, regulated rhythm of repair. You have now faced the internal enemy. But there is one final class of enemies that are neither cells nor alive in the traditional sense. They are ghosts in the machine. In our final lesson, Lesson 19, we will study the elusive world of viruses and fungi. Lesson 19. Antiviral and Antifungal Agents. Welcome to the final chapter. You have journeyed through the entire landscape of human physiology. We have explored the mechanics of the heart, the chemistry of the brain, and the defenses against bacteria. But there are entities in this world that are smaller than bacteria. There are entities that are not quite alive, yet not quite dead. They are the ghosts in the biological machine. Tonight, in our final lesson, we study the drugs that hunt these elusive invaders. We study antiviral and antifungal agents. This is the most difficult challenge in pharmacology because the target is often hiding within us. Unlike bacteria, which build their own walls and run their own factories, viruses and fungi are intimately tied to the host. To kill them without killing the human patient requires a precision that borders on the miraculous. Let us begin with the viruses. A virus is the ultimate parasite. It is nothing more than a strip of genetic code, DNA or RNA, wrapped in a protein shell. It has no stomach. It has no energy. It cannot reproduce on its own. To survive, it must hijack a living cell. It enters your cell, sheds its coat, and inserts its genetic code into your own machinery. It turns your cell into a virus factory, forcing it to churn out copies until the cell dies and bursts, releasing thousands of new invaders. Because the virus uses your ribosomes and your enzymes to survive, we cannot simply poison the factory, or we would kill the host. We must target the few specific steps that are unique to the viral life cycle. Consider the herpes virus. It hides in the nerve cells. To replicate, it must copy its DNA. It brings with it a specific enzyme, a viral DNA polymerase. We have designed a drug called acyclovir. Acyclovir is a master of disguise. To the virus, it looks exactly like guanosine, one of the building blocks of DNA. The virus grabs the acyclovir and tries to add it to its growing DNA chain. But acyclovir has no attachment point for the next link. It acts as a chain terminator. Once the acyclovir is added, the DNA chain snaps, the copying stops, the virus cannot reproduce. Crucially, human DNA polymerase is smart enough to ignore the fake block, so our own cells are unharmed. This is the elegance of the suicide substrate. Now, consider influenza. When the flu virus finishes replicating inside your cell, it pushes out through the membrane to infect the next cell. However, it gets stuck. It is tethered to the cell surface by a sugar molecule. To escape, the virus uses a pair of molecular scissors called neuraminidase. It cuts the tether and flies free. The drug oseltamivir, known as Tamiflu, is a neuraminidase inhibitor. It puts a sheath over the scissors. The virus replicates successfully, but it cannot leave the cell. It remains tethered, trapped and harmless, until the immune system arrives to sweep it away. But the greatest triumph of antiviral pharmacology is the treatment of HIV. HIV is a retrovirus. It carries its code in RNA. To survive, it must convert that RNA into DNA and stitch it into the human genome. It uses an enzyme called reverse transcriptase. We developed drugs to block this enzyme, reverse transcriptase inhibitors. Then, we developed drugs to block the enzyme that cuts the viral proteins protease inhibitors. Then, we developed drugs to stop the virus from entering the DNA integrase inhibitors. By combining these drugs into a cocktail, often 3 different mechanisms in one pill, we prevent the virus from evolving resistance. If the virus mutates to beat one drug, the other 2 are waiting to catch it. We have turned a fatal diagnosis into a manageable chronic condition. Now, we shift our gaze to a different enemy, the fungi. Fungi are not simple like bacteria. They are eukaryotes. This means their cells are complex, with a nucleus and organelles, just like human cells. This makes them incredibly difficult to kill selectively. If you poison a fungus, you are very likely to poison the human. However, there is one crucial difference. The cell membrane of a human is stabilized by a lipid called cholesterol. The cell membrane of a fungus is stabilized by a lipid called ergosterol. This single molecule is the target of almost all antifungal therapy. We have 2 main strategies here. The first is the gentle blockade. These are the azoles, like fluconazole. These drugs inhibit the enzyme that builds ergosterol. Without new ergosterol, the fungal membrane becomes weak and leaky. It cannot grow, the fungus stops spreading, and the immune system cleans it up. These drugs are generally safe and are used for common infections like yeast or athlete's foot. The second strategy is the nuclear option. This is a drug called amphotericin B. In the hospital, it is jokingly nicknamed amphoterrible because the side effects are so severe: fever, shaking, and kidney damage. But for a life-threatening fungal infection in the blood or brain, it is the only choice. Amphotericin B does not stop the production of ergosterol. Instead, it hunts it down. The drug molecule binds directly to the ergosterol in the fungal membrane and rips it open, punching a physical hole in the cell. The contents of the fungus leak out, and it dies instantly. The danger lies in the fact that ergosterol is very similar to cholesterol. If the dose is too high, the drug starts punching holes in human cells too. It is a calculated risk to save a life. There is a final class of antifungals called the echinocandins. These target the fungal cell wall, not the membrane, but the outer shell. They block the production of a sugar called beta-glucan. Since humans do not have cell walls, these drugs are very safe, often called the penicillin of antifungals. They represent the future of this field. Let this knowledge settle. The virus, the ghost code. Acyclovir, the fake block that snaps the chain. Tamiflu, the sheath on the scissors. The cocktail, the trap that catches the mutation. The fungus, the cousin of the human cell. Ergosterol, the Achilles heel. Fluconazole, the starvation of the membrane. Amphotericin, the punch that breaks the wall. You have now completed the entire curriculum. Think back to the very first lesson. We started with the simple idea of a drug binding to a receptor. We have watched that concept grow, branching out into the nerves, the heart, the lungs, the gut, and finally, into the war against the invisible world. You now possess a map of the human body's chemical landscape. You understand how we speed it up, slow it down, protect it, and repair it. You understand that medicine is not magic. It is the precise application of molecular logic. Let this vast amount of information compress itself. Let it become a heavy, warm blanket of knowledge. You do not need to remember every name or every enzyme right now. The concepts are stored. Your mind has done the work. Now, the only task remaining is the most important biological function of all: recovery, restoration, sleep. Let your own chemistry take over. Let the natural sedatives of the brain rise. Let the eyelids fall. The class is dismissed. Good night.